go ahead and get started. To start us off is Dr. Daniel Fain, and he will be presenting today on maximizing quality of life in pediatric epilepsy care. Dr. Fain is a pediatric epileptologist from Helen DeVos Children's Hospital, a longtime volunteer for Camp Discovery, and a professional advisor for the Epilepsy Foundation of Michigan. So Dr. Fain, thank you so much for joining us today. You can take it away.
Thank you, Russ. Okay. So this is just a disclosure. I am currently involved in a study that does not have any impact on what I present today. Also, a little bit about myself too. I have had an epilepsy focus for some time. More recently, I have had a more inpatient neurology, inpatient pediatric neurology and stroke and neurocritical care focus. So our primary epilepsy team consists of 4 other doctors that do more work with the EMU and things like that than I do, but I still have a lot of patients with epilepsy that I follow. I'm also very happy that Dr. Khalil is here today. She can help answer some of these questions, and it's very nice to have her, and she's a wonderful colleague. So this is definitely a focus on quality of life, and we know that epilepsy is a spectrum. Just something to keep in mind is that about 2/3 of patients with seizures have controlled seizures. Their epilepsy is either controlled with lifestyle or medications or other things that keep them from having seizures, and about 1/3 are uncontrolled. So there's a broad spectrum of possible outcomes and difficulties that are experienced by patients with epilepsy. Medication selection and management is certainly very important. Just for an example, it wouldn't do very much good for a person to have well-controlled seizures on medications that make life very difficult because they're too sleepy, not able to function, nauseous, anything like that. We're going to talk about some non-medication treatment options, some exciting things that can be offered to patients when medications aren't working. We're going to cover mental health and cognitive functions. And then we'll discuss the role of patients with epilepsy taking over their own care and how to sort of help your child with epilepsy do that. That's a process that can be fostered by your epileptologist, by your medical team, by you. And this is a wonderful opportunity to have your child grow up to take control of their own medication regimen, of their own appointments, and taking care of themselves. So a lot of factors go into quality of life. The first 3 mentioned there are just kind of the basic fabric of who we are: physical, mental, and cognitive health, and how that's impacted by our epilepsy or by medications. Social well-being, how well someone fits into the social fabric, to the community, and for the community support that they have. Life satisfaction. There's a lot of factors that go into someone's just being satisfied with their life. If things are going well, going not so well, what can be modified there? Academic achievement, employment are factors that go into just how well you're functioning. If we're talking about adults, we're talking about an employment situation, jobs that are appropriate, maximizing academic achievement for students, obviously, in this back-to-school environment we're talking about. Independence and self-determination, of course, are very similar. If you have the ability to set your own course and decide what you want to do in life, that's what we all want, and that's what we want for everybody, and want to give everybody that chance. And then the other factors there are kind of the nuts and bolts of just basic day-to-day activities. Are you financially secure? Can you take care of yourself? Do you have a network, a community to help? What's your spiritual well-being? That's just as important. Everything on the right there is just as important as everything on the left. So we'll try to cover that and give some examples, give some tips, have time for questions. So this is a graph of quality of life. And so this is a self-reported number of unhealthy days for different patient populations there. We see patients with no history of epilepsy on the far left, patients with inactive epilepsy, so a history of seizures but not currently. In the next column, next one would be active seizures. Next one would be active seizures but no seizures in the past 3 months. And then the last is the least controlled patients, patients with epilepsy that are having still seizures, one or more, over the course of 3 months or so. And so what you can tell from this graph is that obviously on the far right, people that are having the most seizures report the most number of days that are not healthy. And that can be from those three factors that are listed below, either physically unhealthy, mentally, or limitation of activity. And then the top green line there is just the overall score. So the take home from this graph is that everyone with a diagnosis of epilepsy, for the most part, has a number of unhealthy days that are higher than those without. That is just across the board. And so we would expect this with patients whose seizures aren't controlled. But even for patients whose seizures are controlled or are having very few seizures, there still is a very significant number of unhealthy days that they're experiencing per month. So the slide is to tell you that your epilepsy is not just about seizures. Other factors go into why you're not feeling well. Could be medication side effect, could be worry, could be depression, could be all kinds of things. But even in the patients who are best controlled with epilepsy, there's still a significant number of days that they are not up to peak performance. This is a graph that kind of combines a couple of two different graphs. I'm sorry, a slide that combines two different graphs about epilepsy severity. So we have this concept that epilepsy is a continuum. There's everything from mild to severe, mild on the left end. So seizure free, somewhere in the middle is rare seizures or just seizures that aren't so bothersome, focal aware seizures. In other words, a minor seizure that doesn't cause a significant degree of distress. And then on the right is intractable seizures. Going along with that is intellectual disability or significant physical disability. When people report quality of life impact, there's a range of possibilities of what that is. For people with mild epilepsy, their concerns are typically more mild than those that are mentioned on the severe end on the right, but still they're significant. Fear of having a seizure is a very significant thing, even if you haven't had one in a year or more. Just the amount of time it takes to go to the doctor, go to your epileptologist, time to go get your medications, expenses for meds, the fear of not being able to drive, those are all significant factors. On the right, we can see that there are significantly higher risks and higher fears, of course, that stands to reason. If you're having frequent seizures, then you know you're going to have another one. And so your anxiety is that much higher. Costs are higher. The complexity of the medication regimen that someone is on or the need for other treatments, possibly epilepsy surgery or other things, is much higher. For those on the right, there's frequent seizures and the stigma that's associated with that. That's unfortunate in this day and age, but people are still stigmatized for having seizures. And then there are all the other comorbid problems that can happen. So epilepsy is a spectrum of different problems. There's a lot of comorbidities. We talked about possible mental health overlap and other physical disabilities, things that can happen with a seizure that lead to further injury and things like that, unemployment, then just how challenges of taking care of oneself, of having basic needs met. So all of the fears that are realized by people with severe epilepsy on the right hand of the screen are fears that are causing anxiety for the people that are on the left-hand side. It's a spectrum, and there's always this fear that the epilepsy will get worse, or if it is bad, then you're living in a condition that is very difficult for you. So what about epilepsy prognosis? It's not an exact science. And for some of you, I realize this is probably a new diagnosis for either yourself or your child, and you wonder what's coming next. What can I expect? Well, for the most part, epilepsy can be well controlled with medications or with lifestyle changes, as was kind of alluded to in some of the previous graphs. For the majority, it's a diagnosis that is definitely life-changing but manageable. Things that would tend to indicate a more favorable prognosis include if the epilepsy is self-limiting, in other words, if the seizures are brief or very infrequent, if there's a strong response to the first treatments. In other words, if the seizures just go away, if there's only a very few of them, or if they're controlled by the first medication that started. If we don't have a cause, it's generally a better prognosis. That might sound kind of strange, but in looking for causes, if we don't see any structural problems, if there's not a genetic issue, if there's not a prior severe brain injury or something like that, then generally seizures are easier to control. And if the neurologic exam is normal, that's also a favorable prognostic factor. Unfavorable factors include the severity of the epilepsy. If the seizures are frequent, if they're not controlled with the first medication, then we're very concerned that this could be a very difficult type of epilepsy to treat. If there's a structural problem, if there's a problem with the brain, if the brain tissue itself is abnormal, if there's been an injury or there's a developmental abnormality, then that can lead to a worsening of prognosis. Or if the problem is metabolic, in other words, the body is not breaking down substances properly or is not able to properly utilize certain substances, then that presents problems for treating seizures because you can't go in and just correct that metabolic problem typically. There's things that can be done, but it's not easily corrected. If the neurologic exam is abnormal, that also tends to suggest more difficult problems with treatment. And then if there are intellectual disabilities or cognitive deficits, that can also be a factor. So typically the first treatment is with medications. And there's two basic ways that someone with epilepsy who initially presents will be treated. The first and probably the most common is to look at a rescue medication. Maybe this was just a one-time seizure, or maybe there's only been a couple of seizures, and a person doesn't fit into the category that we mentioned previously, where there's a known structural problem or metabolic or an abnormal neurologic exam, then rescue medications might be the first step. In the past, these have typically consisted of either a suppository medication or a wafer that can be put in the mouth and swallowed if someone is aware enough to do so during their seizure. We now have nasal medications that can be used, and that's been very helpful for patients and in protecting dignity and things like that. If before we didn't have the option, it was mostly just doing a suppository, then this is a new resource to be used, and it's generally very well tolerated and much easier to use than a suppository medication. Chronic management to prevent seizures has to do with daily anti-seizure medication administration. For more frequent seizures, this would be done. I should also point out that this is also done in conjunction with rescue medications. In fact, rescue medications can be a part of the seizure plan for all of these therapies that are discussed on this slide. Surgical resection is another possibility. There is some indication that patients are, in a lot of cases, not getting to a center that can provide a surgical evaluation soon enough. I think this is definitely improving in it. It has been a chronic problem, but as more comprehensive epilepsy centers are being founded, I think surgical intervention is something that can be offered sooner. In patients who are not surgical candidates, devices can be used. Vagus nerve stimulator is one, responsive neurostimulator, a second, and deep brain stimulator is a third. We'll talk about the first two with subsequent slides. DBS is something that is newer, and there are relatively fewer patient cases, but is an exciting new therapy. And we'll go over some diet therapies as well. There's often a question with the onset of seizures is, does my child need a special diet? And the answer is no, not usually initially, but specialized epilepsy treatment diets are definitely available and can be tailored to the family somewhat for those patients who didn't tolerate medications and might not be a surgical candidate or another candidate for another procedure. So how to select medications? Kind of the basic take home from this slide is maximizing seizure treatment and minimizing side effects. So the goal is always the gold standard would be no seizures and no significant side effects for medication. That's something that, especially, considering this being a back to school conference, things to think about for children going to school. You don't want them to have side effects with meds that are going to limit their learning, or want to try to decrease those side effects as much as possible. So the first thing is medications must be chosen to the seizure type. There are certain medications that can make seizures worse if they're not properly chosen. The second would be to look at the side effect profile. That may not be the same for everybody. In fact, for the same two patients, someone might tolerate a medication well and somebody else might not tolerate it very well at all. And so that needs to be taken into account. Interactions with other medications that they're on or other treatments. If these are patients with other chronic conditions, they may be on medications to treat cardiac problems or asthma or something like that. So we have to be careful of that. Pharmacokinetics just has to do with how the body is metabolizing that medication and the timing of giving the medications and how frequent and the dose and all of that. There might be other things that are going on too, like either mood problems, bipolar disorder, or migraine, and treating the epilepsy might actually treat that condition as well. There can be problems with either weight gain or weight loss, depending on the medication or the treatment. That's something that needs to be taken into account. Dosing and mechanism of action need to be considered. Mechanism of action we'll talk about a little bit more as far as what the possibility for for medication side effects would be. A huge thing though is this medication going to be paid for? Is it going to be covered? Can the family afford that? And that needs to be considered by the physicians who are ordering these meds. What are the monitoring requirements? Is there blood work needed? Are EKGs needed? What about contraindications? For an example, some seizure medications might not work so well for females of childbearing age who are on oral contraceptives. There may be interactions there that have to be carefully considered and discussed if a medication is going to be prescribed for these girls and women. What other meds were tried? That needs to be taken into account as you go forward as well too. And then how about the form? Liquid, can the patient take a liquid or a sprinkle, dissolvable? And then patient and family preferences are definitely very important. It's important to get a lot of choices, and so you can make that decision for yourself or your child. This is a list of older anticonvulsant medications, so I'm not going to really go through these by name and discuss things specifically. It's just to say that you may be on one of these. They have been around for quite a while. I believe the newest medication on that list is Depakote. Depakine valproic acid is the generic name. And that came out in the late 70s. And so some of these medications are quite a bit older. I can tell you that phenobarbital is over 100 years old and it's still being used and is still can be effective in certain patient populations and for certain people. Also for certain genetic conditions, that's something that needs to be considered as well, now that we have more information about um, genetics and cause of epilepsy. Some of these older medications have been found to be fairly useful, but they do have more side effects. And one thing to consider is that while we have new medications, thankfully, and newer ones are coming out all the time, they're generally more expensive. But side effects are less, and that trade-off may be huge. If you have a medication you can't tolerate because of side effects, but you have a newer one that can be used, and they both work, then the choice would be to go to the one with least side effects. Another slide of the newer medications. Some of these actually have kind of limited use, and so I don't want to sort of give the idea that these are all equally effective. And if you are on one of these and have a question, we can certainly get to that at the end of the slides as well. I will say that, and I don't know if you can see my pointer here.
Yeah.
Is on. Good. Okay, good. That's good to know. Cenobamate is I believe, the newest on here. I don't currently have any patients who are on that medication, and it's approved in adult epilepsy. However, its mechanism of action is still similar to some old ones. It is a sodium channel agent, as are a lot of these. So these are meds that have generally come out in the past 30 years or so. And it's probably, for a group of this size, there's probably a lot of familiarity with some of these. So the general take home here is that even though we've had a lot of great medications come out in 30 years, there could be still a cost factor, and there's definitely a factor as far as which one of these is appropriate for your type of epilepsy or your child's type of epilepsy. Common side effects are listed there. A lot of these have to do with sort of incoordination, sedation, sort of an inebriated feeling, slowed thinking, unsteady with walking, double vision. I'd add occasionally some nausea or just some stomach being unsettled as well. So these are dose-related, means that if you have a medication and you just push that dose high enough, you're probably going to have one of these side effects depending on the med. Drug-related is more, this is something that's kind of specific to the drug, and is something that could be a problem for you, but may not be a problem for the most part, such as cognitive problems. Some medications can be pushed to a good level for some patients, and they tolerate them really well and are seizure-free. For other patients, if you start them on a low dose, they just are foggy all the time. See, that's not a dose-related problem. That's just the medication doesn't agree with them. And the same thing for the rest of these symptoms, fatigue or sedation. Some patients tolerate meds without any change in weight whatsoever, and some get either loss or gain. You can have hair loss or gain, increased hairiness or hair loss. So cosmetic problems. And these are very important. This isn't to be taken lightly, because this is part of your whole well-being that we talked about on that first slide I opened this session with. Some might cause hyperactivity or personality changes or mood or depression. So it certainly doesn't do you any good to be on a med that's causing side effects, even if your seizures are better, because your quality of life is still pretty poor. These are some warning signs to consider. You should contact your neurologist as soon as possible if you're having any of these, because they could lead to some severe conditions. Things having to do with mouth ulcers and rash and things could be a Stevens-Johnson syndrome. If you're having excessive fatigue or swollen glands or things, this could be something that's causing, it's just a problem with your body's metabolism, how it's breaking it down. There may be some difficulties there too. So these can be serious, but thankfully they are very rare, but definitely this is a reason to contact your doctor immediately. So if medications are started and the seizures continue, what can be done? Well, increasing the dose is something that we do frequently. If we feel pretty confident that the medication chosen is appropriate, then try and increase in that dose. Changing the timing of the doses, maybe the time of day that it's given could be changed a little bit. Maybe we were trying to go for more of a bedtime dosing, but we want to go to twice a day. We also might stay with that medication because we think it has provided some help, and we'll add another one. The other possibility is it hasn't really provided any help, so we'll wean off and add another medication. There's things that can be done with medications. If the first one isn't working well, the take home from this slide here is basically medications might still be the answer. It might be frustrating, but it might not be the first, but maybe the second or sometimes the third. Or it might just be changing some things about how we give the med. So what is the definition of drug resistance or intractable epilepsy? Basically, if you have two appropriately dosed medications and you have not achieved good results with seizure control with those meds, and they've been well tolerated, and the dose has been appropriate, that's the definition of being intractable. And that's where we come up with this slide here and this pie chart. This isn't from an old study that was done basically in the perhaps late 80s or early 90s, but it still holds true today. And that is that a very good proportion of patients with epilepsy will respond to the first medication. If you add a second, you get a response that's about 14% better. So about half will respond to the first, and then you have between 10 and 15% with the second. And so there together, you've got a pretty good response rate of about 60%. But then adding a third doesn't really get you that much more. It's only a few percent after that. And then you have this fairly large chunk of pie here, this part that's in purple. A third of patients are just not controlled on medications. However, before calling them epilepsy intractable, we have to make sure that there's some things that we really check off before we do that. The first is, has the patient really been taking their medications as prescribed? That can be a problem. Maybe it's because they're having a lot of side effects and it's not their fault. They just don't want to keep taking a med that's not making them feel very good. But it could be that they forget for other reasons, or there's a lot of factors with their support system at home. They're just not able to do it. Are there triggers that could be avoided? As an example of that, someone with a generalized type of epilepsy may have triggers with flashing lights. And one way this can happen is if they're riding in a car on a sunny day and sunlight gets filtered through trees and they kind of have that photic effect and go into a seizure. Well, if they wear Z1 lenses or lenses that filter out certain frequencies of light, maybe that avoids it altogether. And so that could be a help that's not a medication and that's not causing more side effects. That's something to be considered. Another thing is this epilepsy? Is it actually a non-epileptic event? Non-epileptic seizures are serious and they are fairly common. And the best way to identify them is if you can actually have an EEG going when you have a seizure. But then you can get somebody on the road to the correct diagnosis and recovery that was something you thought was epilepsy, but it really isn't. And that's very helpful too. And some patients have both. Maybe we were not able to identify the epilepsy type at the very first type of seizure. If you have someone with a generalized epilepsy that sort of looks focal, in other words, if you just have staring spells, maybe you can't tell the difference. But if you start someone like that on a certain medication for focal seizures, it might make the generalized seizures worse, or it might not work at all. And then maybe the medication choice just wasn't the right one to start with. So the thing to keep in mind is that the likelihood of seizure freedom is low with drug-resistant epilepsy, but you have to really make sure that that epilepsy is truly drug-resistant first. This is just a slide that discusses comprehensive epilepsy centers. So these are centers where patients can be monitored, where they can be diagnosed, and then where surgical and non-surgical treatment can be performed. So these are epilepsy surgery centers. These are centers with long-term monitoring and with a core group of epileptologists who are caring for these patients, and where devices can be placed too. Dr. Khalil is on right now. She is a wonderful epileptologist in Lansing, and so her center is not yet comprehensive, but she does a lot of long-term monitoring of EMU. And when you think about it, most of the patients with epilepsy don't really need to go to a comprehensive epilepsy center. And we have worked very closely with her in helping some of her patients, and she's been extremely helpful for the patients that she cares for. So treatment considerations are, can we give this treatment? Can we provide this to the family? And will the family be able to do it? Is it appropriate for the patient's type of epilepsy? What tests need to be done to find out if surgery is needed, or if a diet therapy is needed, or something like that? Seizure outcome, how likely is seizure freedom? We know that there are unfortunately some epilepsies that no matter what we do, it's going to be very difficult to make a patient seizure free. And so then we have to think about, well, then what's best for the patient? What's best for the side effects? What kind of treatments can we offer? Risks. How is this going to be a risk to the patient? What is going to be better? Is it going to be pursuing this treatment, this device, or this surgery, or is it going to be not pursuing it? Can it be reversed? Is this something that's reversible, or is it permanent? Are we committing this patient to something that we wouldn't, that they might not be able to do or might not want to do in the long run? And then benefits and risks for seizure control. Is it going to allow the child to come off of medications, and can it improve cognitive functioning? So epilepsy surgery could be resection, just going in and removing a zone of the cause of the seizure. So this could be a lesion. In other words, you might find something that's on the MRI. So for instance, cortical dysplasia is a term you might have been told or have heard about, and it's an area that's abnormal in the brain tissue and causing a lot of seizures, and that can be taken out, or the zone around it can be taken out. Temporal lobe is the most common, but other areas can be resected as well. It may be lesional or non-lesional, and a non-lesional surgery means that on MRI and on other studies, we don't see anything that looks abnormal, but we know that's where the seizure is coming from. Frequently, there's going to be supporting tests as well. I didn't really go into this at all, but SPECT scans and PETs, and there's going to be other types of scans that will show that that area is abnormal too, including the EEG. Ablation means using heat from a laser to kind of destroy the seizure focus. Visualase is the type of laser system that's often used. Disconnection can be done. Corpus callosotomy, cutting that thick strip of tissue in the middle of the brain, or just separating the brain tissue so that it's not connected to other areas. In other words, you can separate out a seizing area of the brain and keep it from causing the rest of the brain to seize. And then there's just some mention of what the pre-surgical evaluation is. It's a very detailed process. Neuropsychology is very important to know about patient functioning. Assessing the family and whether they're able to care for a patient after surgery and things like that as well too. So all of these tests can be important. I'll just touch briefly on MEG as magnetoencephalography. And so that's usually using, instead of electrical waves to look at the brain, it's using magnetic fields. Risks are usually transient side effects. So after an epilepsy surgery, people are going to have some degree of discomfort, headache, swelling, things like that. but complications are usually pretty low, things like stroke or infection or things like that. Also, there are typically some functional deficits that are temporary, memory or language difficulties, things like that, that do not continue for long term, but they can be. You could have some long-term deficits depending on the area of the brain that's involved. The larger the area that is either disconnected or taken out, the more risk for having long-term side effects. Seizure-free rates vary. It depends on the part that is removed. Temporal lobe tends to be more highly associated with seizure-free rate than extratemporal, so other areas of the brain. And then if there's a lesion that's taken out, in other words, you can go in and take out a focal area of a tissue that's abnormal, then the rate of improvement is going to be higher than if it's not a lesion identified. Seizure-free might be a relative term if you a patient is just experiencing focal aware seizures. In other words, they know they're having a seizure, and it's just brief. That is sometimes about as good as an outcome as it can get. They might have had surgery, go and then come off of medications and then continue to have these types of seizures, but then have to go back on the medication. But the outcome is still much better because they are having just a very brief seizure where it was very severe before. Vagus nerve stimulator is an implantable device that stimulates the vagus nerve. There's on that picture, you can see where it is placed, usually somewhere on the left side of the chest. Surgical approaches can be used to kind of even hide the scar. So some surgeons can go through the axilla, through the armpit, and kind of implant the device deeply. There's a tunnel that's made and then a small incision in the neck so that the wires can go to the vagus nerve. So why does this work? Well, the vagus nerve is an extensive nerve network that goes to the thalamus of the brain. That's kind of, the thalamus is the executive secretary of the brain. If we stimulate the thalamus in turn stimulates the surface of the brain, the cortex. And with long-term use of this stimulator, that can slowly change seizures to decrease and for seizure pathways to become less strong, and it can actually change the brain wiring over time. The three modes that can be used are that it can be just the standard or the preventative. So the device goes off. It doesn't deliver a constant impulse. It's in little bursts, and it's usually in variable amounts of time. And so the example there is sometimes it goes off for 30 seconds every 5 minutes. That alone can decrease seizure frequency, and sometimes that's all patients need. In addition, there can be a longer impulse that's given when a magnet is swiped across it. And so if a patient is having a seizure, then a family member can swipe the magnet and the seizure can be hopefully stopped that way. In addition to this, there's the responsive mechanism. So one thing that typically happens with seizures is that the heart rate goes way up. It spikes up very quickly. The device sits there and it monitors heart rate, and when it sees that, it can deliver another impulse. It can deliver a longer impulse. It's almost like automatically using the magnet. Now, people wonder, well, what happens if, say, my child is out playing and running around and the heart rate goes up? There are some programming parameters that can help with this. We don't want it to be too sensitive, and every time there's a very slight decrease, a slight increase in heart rate to go up. But we want it to recognize at least sometimes when heart rate goes up and stays up that is a seizure. And that can be done a little bit with the programming part of this. What happens is this device can be interrogated through the skin, so nothing painful at all. There's a wand that's held over it. And then information for the past period of time since the last interrogation can be seen, and the parameters can be changed. It can be made to go off for a longer period of time. The heart rate detection might be increased or decreased in sensitivity. there's all kinds of ways to change the programming to help improve it. So what are the risks? Complications are fairly low as far as surgery, but there can be infection as with any surgery. Nerve damage can result. That's pretty rare. What is fairly common is changes to the voice when the device goes off. There's kind of a different sort of a warble that can be seen. Sometimes that causes patients to cough as well too. Programming can help a lot with that though too. If the programming parameters are a little too high, they can be decreased sometimes. So usually the side effects are mild. This is generally very well tolerated. Usually the patients will get used to the things that are happening, and if there is coughing or hoarseness, the programming can be changed. So with the vagus nerve stimulator, seizure freedom is uncommon. However, unlike medications, the longer that the device is in, the better it usually performs. So this is something where definitely patience is required. You might not see good results in the first month or even the first 6 months, but the longer it's there, the more you might see that there's improvement over time. It is significant that 80% reported improved quality of life with the VNS, and that 60% said that they could stop worrying as much about their seizures. So there definitely are some reasons to consider it. RNS, so responsive neurostimulation. Instead of placing the device in the chest, this device is placed actually in the skull. So part of the skull needs to be removed, and then the device is placed just in that area underneath the scalp and underneath the skull surface. You can connect up to 4 wires, and so this is helpful for certain hotspots of seizures that are occurring in the nervous system that can be identified, and then those specific areas can be stimulated with the responsive neurostimulator. It's FDA approved for ages 18 and up, but children have been implanted. We've had a couple of cases at my institution here in Grand Rapids with fairly good results. Complications have to do again with surgery. Let me see if that's on the next slide. Yeah, I'll just kind of go through that. So surgical complications are again fairly low. Some people report continued discomfort because it is a skull surgery, but usually it's less than a year. Device malfunction is rare, but what happens is after device is implanted, there's a lot of programming that needs to be done. So people are put on EEG, they're monitored, and then the device can be changed as far as how it functions, what it stimulates, how much it's stimulating, how often, all that kind of thing. And that can take a lot of programming, so it can be very labor intensive. So there is a slight risk of damage when this is going on, but it is slight. Again, long-term seizure freedom is uncommon, but it is pretty significant that 1/3 of patients reported at least 6 months of seizure freedom, which is really good for this population that hasn't been able to respond to other things. Average seizure reduction of 72% at 7 years. And then, as with the VNS, a fairly significant proportion of patients also reported improvement in quality of life. Moving on to diet therapies. So again, diet therapies are useful for patients with intractable epilepsy. There's usually, I will say, a lot of questions, and maybe you have some questions too about, well, my child was just diagnosed with epilepsy. What should I do? What should I do for a diet? And if we're at the stage where seizures are being diagnosed and we're just starting medications, my usual response is you need to you have an appropriate diet for your child that is pretty much a healthy diet that any child of your child's age would have. And that's going to depend on whether your child is an infant or is a toddler or a teenager, etc. There's really no indication that starting a diet early is going to be helpful. What we're talking about here is patients that have failed medications and don't seem to be a candidate for other types of interventions. Or in some cases, we know that they wouldn't be a surgical candidate, but we can go pretty quickly to a diet therapy. Or there are certain patients with metabolic conditions where we know that diet is kind of the first choice for therapy. Those are very rare. Um, we're talking about metabolic conditions. We're talking about conditions where the brain doesn't get enough glucose. If those are identified, then we know that this is more or less a first-line therapy or very close to first line. But of the 5 types of diet therapies that are used, the classic ketogenic diet is the one that is the highest in fat. And so this is a very low carbohydrate and a very high fat content. Now I can recall years ago, especially when I was in training, what this diet consisted of, and it's nothing like it used to be. The dietitians have done a fabulous job of making this a more palatable diet, a more palatable situation for families with children who need to be on this. It is easiest, I will say, for patients who have a G-tube, and because it can just be made up as a formula. And so that's something that the family doesn't have to worry about weighing things and all that kind of stuff. But this can be done even for children who are older, who feed orally, who can make their own food choices. So classic ketogenic diet, though, is definitely the highest in fat. And so the classic is the 4-to-1 as far as the carb to the ratio of fat to carbs and protein. Modified ketogenic is typically what we'll start with unless we think that the patient would do better with a different type of diet therapy there. And so, you know, I'm sorry, I messed up. Modified Atkins is typically what we start with. The modified ketogenic diet is less than a 4-to-1, so 3-to-1 to 1-to-1. And we find that this can be helpful. And for patients that aren't tolerating the 4-to-1 diet or that it's just not useful for, this is very helpful. And this is where a trained dietitian really comes in. Our dietitian is invaluable for helping us to make these changes. So for instance, say a child is doing pretty well with a 4-to-1, but there's issues, say there's constipation or there's poor weight gain, or maybe they're gaining too much weight or whatever, then our dietitian can do some calculations and come up with a less of a proportion of a diet, somewhere 3-to-1, 2-to-1, or 1-to-1. And this will help the patient tolerate the diet better. We watch for seizure control and make sure that that continues to be good. But these types of diets are common. I'd say it's more common now for our patients to be overall for keto. We don't have as many sticking with the classic 4-to-1 as much as a slightly lower ratio. And it can be, you know, a fraction as well too, like 3.5-to-1 or something like that. Adding MCT oil to the diet is sometimes helpful for seizure control. So that just is using a special type of lipid for the fat content. Modified Atkins is the most common first diet therapy that we start with for our patients. This can be started as an outpatient, whereas all the above 3, the keto, the patients need to come in and be monitored to start those. For one thing, we want to make sure they tolerate it and that their blood sugars don't drop too low and all that kind of thing. So if you look at modified Atkins compared to keto, the big thing is just that the protein content is much higher, the fat content is lower. The carbs are a little higher, but this is basically just going with a low-carb diet, and it can be done at home. It can be started at home. Definitely you need to have a dietitian help a family through this and give them all the information and how to do this, but it can definitely be done. Low glycemic index, we don't do as much. Some of our patients, interestingly, there's a similar diet called the whole foods diet. And so these are less severe and they can help. We look at these often, I would say where this is helpful is with our teenage population who the seizures are fairly well controlled, but we can sometimes get a little bit better control with medications plus the low glycemic. So you have to look at several things here, including are the parents able to do the diet? Do you have a dietitian who's available who can help? So one big question is, what happens if a child gets sick? Well, what do you do for a sick day? They can't be on the diet because they're vomiting, etc. That can be a big problem. And so there are some answers to that. It might be actually increasing the sugar content a little. It might be having them come in for IV fluids, all those kind of things. The other thing is if a patient with a ketogenic diet is admitted for procedures, for tests, for surgery, for illness, that has to be taken into account as well for the type of fluids that they're going to get and things like that. So is the diet for you? It depends on a lot of factors. It depends on if you can use it, if you can do it or not. The ketogenic involves a lot of measuring, a lot of weighing, a lot of keeping track of the child's weight, and that can be very time consuming, and it can be very expensive. Risks, GI problems, hunger, slowed growth, increased growth, kidney stones, high cholesterol, all of those are possible. About half of the patients who try ketogenic are responders if they can get into, if they can do it properly. So that's something to keep in mind. And then certain epilepsy syndromes, it can be a pretty good treatment for. And a lot of these are ones that we don't have a very good treatment otherwise. Again, I'm not going to go into all of these syndromes and things like that. I will focus in a little bit on the GLUT1 deficiency. That was what I talked about as far as brain glucose is low, and this is more or less kind of a first-line diet for these patients. So maybe your child has been diagnosed with one of these syndromes, and you want to talk to your epileptologist further about that. There is some limited function. So a lot of concern is, what about having my child on a high-fat diet for a very long period of time? So that is a concern. Again, if you have a dietitian who's monitoring growth and things like that, that's very important. But overall, cognitive improvement and function may definitely outweigh some of those side effects and those concerns. Well, now we get to more things that are directed by the family. A lot of families want to try supplements. They want to look at CBD and how that fits in with their regimen. Maybe you want to use chiropractic care. You want to use yoga. You want to do things that have worked for you otherwise as a family, and you want to know how that's going to help your child. And the answer is that these things can be very helpful. It's just important for you to discuss this when you see your neurologist about what you're doing, and especially if it's a supplement or if it's something that's given, obviously orally or sometimes applied on the skin. Your doctor needs to know how that might interact with the other medications. Therapies can be very wide-ranging as far as their safety and things like that as well. For instance, if I have families that are like to avail themselves of chiropractic care, I just talk a little bit about being careful with the chiropractor about not doing, neck manipulations and things that could be unhelpful or could be serious for the child, because otherwise, most of the therapies that are done are helpful. They're beneficial. They can lead to better well-being. What about things that are patient-directed? Meditation, prayer. Those things are very important and need to be fostered. This could honestly be a complete talk in and of itself as far as what's going on, and we could probably have a lot of networking with just the families that are on with what is being done that can be helpful. And I'm sure that you do on Facebook groups and things like that. You talk about different supplements that you found to be helpful. The thing is that these are can be just as important as the other therapies. So whatever you're doing, bring a list in and talk about that during your visits. What we need to talk about now, though, is comorbidity. So anxiety, depression, it's actually uncommon to not have something else along with epilepsy. And so what we're usually talking about is a mood disorder. These definitely impact quality of life and need to be addressed, and this needs to be treated as well. it's helpful. There are some mood screening tools that can be done in your doctor's office, and it can be helpful for you to ask about that, especially in your adolescent patients and teenage patients, just to do one of those tools to see how much stress is playing a role in everything that's going on. So counseling, psychotherapy, we have a very good neuropsychology team that helps us with our patients, and good psychologists and psychiatrists. It's on us, the physicians, to ask questions about how you or your child are doing to make sure we address everything. And if your doctor, and I'll certainly put this on myself as well, if I'm not asking you about mood and about your child's quality of life, I'm really not doing my job. So cognitive side effects are definitely an issue, and a lot of epilepsy syndromes, we talk about LGS there, or Dravet, can have profound quality of life issues because of intellectual disability, and that may include autism as well too. This needs to be addressed with IEPs for school. Make sure your child is getting everything they need to maximize their education. Memory problems are also a big concern. This is a problem just with epilepsy, but it can be with treatments as well too. And so this is just another reason to bring a neuropsychologist in to help your child. This can be a very important doctor to come in and sort of look at your child as a whole person, take a holistic approach and see what's working and what isn't, and what can be done, and how can we make school most effective for your child. The key to self-managed behaviors are knowing how many seizures your child is having, or if you're suspecting seizures, write those down. We want to know about that. That's going to be one of the things we discuss when your child comes in for a visit. Just how well are we doing? Is the seizure frequency increasing? Is it decreasing? Do we need to do an EMU evaluation again? Medication adherence. Try to keep track of missed doses. Try to do what you can do to keep from missing doses using alarms and pill boxes and things like that. Sleep is extremely important. If you're not, and that's something I always ask about at appointments, your child needs to be sleeping both quantity and quality. So length of time and amount of time. We do a lot of sleep studies because we want to make sure that obstructive sleep apnea, which can also happen with epilepsy, and that's something I should have brought up with the VNS. That can be a concern, as some degree of sleep apnea too. So sleep is definitely important. Anything we can do to help that. And it doesn't necessarily mean a sleep medication even. It might mean checking labs. It might mean checking your iron level, thyroid, other functions to see if we're doing a good job, checking medication levels. Stress management. Everybody is stressed. Keep the doors of communication open for you and your child as far as to talk about that stress. Know your child well. Know what those causes are. School is a big source of stress. Going back to school right now is exceedingly stressful. Talk that through. Make sure that there's not something that your child is hiding that is causing them a lot of stress. We want to encourage kids with epilepsy to be as much like normal kids as possible. I mean, by that I mean kids without epilepsy. We want them to be active, to exercise, being healthy as far as their eating. For older kids, it means avoiding drugs and alcohol. Other healthy behaviors, knowing their body well, knowing when they need to take a rest, knowing when when things are too much. When is it time to take a break? When is it time to call their psychologist or their therapist? We want to just kind of instill that in them. That leads well into the next slide, where we have transition of planning. Your child is growing up. We want your child to be able to take care of her life and managing his or her epilepsy as they get older. So we start with questionnaires at about age 12, and we have about 4 steps to getting your child to the point where they feel confident that they can make their own appointments, where they can know their medications well, their pharmacy, when to call with problems, what tests they're going to get, when they need to get another test. really to kind of take ownership of their epilepsy, if that is possible, because some children are impaired and they cannot do this. So working with your child as far as their goals, maybe your child's goal is to drive. How can we get them there? How can we keep them seizure free so that they can do that? I love it when kids come in and challenge us. You know, they will sometimes do that. I had a patient come in one time and say, "Why didn't you talk to me about SUDEP?" And it was an excellent question, and for some reason that just hadn't gone on the list. I will say that not every child is at risk for SUDEP, and most aren't. But if somebody that is, so SUDEP is sudden unexpected death in epilepsy, and that happens in patients with severe epilepsy or patients who are medication non-compliant or with certain types of epilepsy syndromes. And so sometimes this can be something a child worries about, but maybe they're not really at risk for it. For older kids, for teenagers, it's good to bring that up because it's out there. If they read about it, they're going to wonder why you didn't talk to them about it. And if they bring it up, it's a good thing to discuss, obviously. So we're going to just kind of go through here. Just these websites and numbers can be definitely helpful for Epilepsy Foundation resources. And these are available. They're on the website. These will be available to you anyway, too. So just some other Michigan related. I realize you're not all from Michigan, but for those who are, some other websites and some other things. Things like the American Epilepsy Society. So this is for anybody. Obviously, that's an international organization, as is ILAE and Child Neurology Foundation. So I'm going to open it up to questions now, and I'm going to try to get back and see. I know Russ has been looking through the chats there, and we probably have some questions. I think. Yeah. If there's things you want me to go back to or to finish up more, I can do that as well. But should I just keep the slides up for now, or should I unshare?
You could end screen sharing and we can put up a static slide for now. But I'll get started with some of the questions. So we'll try to get through as many of these as possible. And thank you, Dr. Fain, for an excellent presentation. So how do you know if your child isn't metabolizing their medications properly?
Yeah, that's a good question. I'm also going to say that Dr. Khalil can jump in here at any point too. She's an invaluable resource for a lot of this information too. So if a couple of things, if it's an older medication, then often levels are used. So for instance, Tegretol is a fairly easy medication to tell if your child's metabolizing well or not, because if we give it a certain amount, we should know that the dose or that the level in the blood is going to be a certain amount as well too. Now this isn't as an exact science, and your child isn't, you know, a lab rat that we can tell every time what's going to happen. But for one thing is levels. You know, can be an issue. Another is your child absorbing the medication well or not? Again, that might be done by levels. Side effects can be helpful too. If there's a lot of GI side effects and your child's seizure control is still poor, then maybe that could be an absorption issue or something like that. Maybe your child is a fast metabolizer. Where this usually comes up is where there's more than one medication. If we add phenobarbital to, say, Tegretol or to oxcarbazepine or one of the other ones like that, we know that's going to induce metabolism. It's going to rev your liver up, and it's going to be metabolized faster. So it has to do with blood work, with knowing what the medications your child is on, other medications that could interfere, and seizure control.
Okay, great. Regarding medication selection, what are your thoughts on generic versus brand name meds? Our child has had adverse reactions to generic meds, and we're curious how to know whether this is common with anti-seizure medications.
This comes up. I do have patients on brand name medications. It seems that they do the best with those. The research indicates that the majority of patients will do just as well with a generic as with a brand name. We think that there are some factors, and some things are a little bit beyond your control. For some children who've had some difficulty with seizure control, it might be that the manufacturer of the particular generic changed. So the amount of specific drug that's present may be slightly higher, slightly lower, something like that. So that does happen. But for the most part, and there's been research to support this, generic is as good as brand name with some exceptions. And when we get those exceptions, we definitely take that into account.
Okay, great. Can changes in administration of medications cause sleepiness, moodiness, or defiance?
So the behavioral part, the short answer to that is yes. So if by that you mean, say you're going from a liquid to a tablet, you might have to adjust the total amount a little bit, up or down or something like that. There can be just some interesting changes as far as that goes. If you're talking about splitting up the medication, if you're talking about, so I'll throw out there one that is fairly common that does have a lot of mood and issues like this, and that's clobazam or Onfi. Usually it works best as a twice-a-day medication, but it can cause some side effects, especially drowsiness if given in the morning. So sometimes we give it more at night and a little bit less in the morning, and we can get rid of some of that mood, some of that behavior issue that happens during the day. So changing times of administration definitely can be helpful. We know too that medications that require 3 times a day or higher, 4 times a day dosing are going to be more difficult for families to give, and they just aren't going to be able to always give that. So once or twice a day is always better if possible.
Okay, great. Why are dietary therapies not offered at the beginning of the journey instead of when other therapies have failed?
So typically, so I will say that I've had, number one, and I think this is true for patients for physicians that do treat patients with epilepsy. I have on rare occasions tried when the families have really wanted to go that route, depending on the seizures, depending on the severity, depending on what's going on. If this seems to be a case of an epilepsy that I wouldn't normally start a medication firsthand on, like benign relentic epilepsy, just to see if maybe modified Atkins or a low glycemic index for very motivated parents, this can be helpful. The most effective dietary seizure therapies are the ketogenic types of diets. The data I presented there, the most likely to really decrease seizure frequency. Side effects are pretty high with these diets, though. We have to constantly monitor labs. So we want to make sure kids are growing. There can be a lot of vitamins and trace minerals and things like that they might miss out on. And so they're getting poked for labs a lot more than they would be for medications. They can have some GI side effects. If you're having a lot of constipation, that can be very, very limiting. It can be emotionally difficult for a child to start a diet therapy. It can be emotionally a lot easier for them to start a medication. Medications are generally well tolerated and generally are not, they're not as evil as, I guess I'll just kind of be blunt, they're not as evil as some families think. Now, there are families that just don't like medications, and I get that. And I will work as much as possible with doing what they want to do and even trying a diet therapy sometimes. But I can say that for most epilepsy, it's a lot easier to control with medications and frankly safer because we're not putting the child at risk for going into some type of a metabolic deficiency or something like that. And then to qualify that, yes, there are certain epilepsies where diet therapy is firsthand is the best one to go with.
Okay. Is there more of a concern for SUDEP if my child's activity is more at night?
That is one factor. The biggest factors are just how well controlled or not the seizures are. I do get concerned for children with nocturnal epilepsy. In other words, epilepsy that goes on at night. And first of all, let me say that that's for seizures that are proven when we have the child in the epilepsy monitoring unit. We capture those seizures and we know that they're occurring at night. And I say that because sometimes there's a concern that something the child is doing is a seizure at night. It may be a sleep problem, it may be restlessness, it may be a parasomnia. Parasomnia just means that you're, a very common one is something like sleepwalking, but some kids can have confusional arousals and they're not seizures. Having said that, there is a bit of more concern for seizures at night. Not huge for most seizures. The seizures that are most concerning for SUDEP have to do with those that impair breathing and especially heart rate. So I talked about how, a very high percentage of the time heart rate goes up with a seizure. There are seizures that are unusual, and usually it's in children who are severely affected. Their heart rate goes down, and those kind of concerns are very concerning. So overall, if your child's seizures are otherwise well controlled, but they just happen to have had a few at night, that's not a big concern. If you're talking about things like benign relentic epilepsy, where your seizures happen at night, but they're very brief, that's not of concern. If you have a child who's very neurologically impaired or somewhat impaired and is having a lot of seizures that just can't be controlled, that's a higher risk.
Okay, great. So we do have more questions, unfortunately, but we are out of time. So we will make an effort to respond to those questions after the conference. So again, thank you so much, Dr. Fain, for a really comprehensive presentation, and just it really gave us a great sense of all the things that have to be considered when you're thinking about quality of life.
Thank you. My pleasure.
Okay. The title of this presentation or discussion is Communication and Teamwork to Improve Health Outcomes. And we are pleased to have as our panelist Dr. Suad Khalil, who is a pediatric epileptologist at Michigan State University, and Nicole Fitzpatrick, who's a parent of a teen with epilepsy. So thank you both for sharing your expertise today. Unfortunately, Bev Kreider, the founder and CEO of Patient and Family Partnerships, will not be able to join us today due to a family situation that came up. So can each of you start by briefly introducing yourself and describing your experience with epilepsy in this particular topic? Dr. Khalil, would you like to go first?
Sure. Can you hear me?
Yep.
Good. Thank you, Russ, for having us today. My name is Suad Khalil. I'm a pediatric neurologist, epileptologist. I joined Michigan State University here in East Lansing 4 years ago. I used to be at Children's Hospital of Wisconsin in Milwaukee. My subspecialty is epilepsy. I take care of patients with epilepsy, apparently diagnose them, treatment. We are here at MSU East Lansing, an epilepsy center level 3. As Dr. Fain mentioned, there is other centers in Michigan when they are level 4. Basically, the difference is in level 4, this is where you have like the ability to have a surgical evaluation and to do a surgical intervention for epilepsy. I'm very happy to be here and excited to answer your questions afterward. Thank you.
Great. Nicole?
Thank you, Russ, and thank you also for having us on today. Excited to be here and to talk with all of you. My daughter is 15 now. She was diagnosed when she was 7, started having seizures. We have no family history of seizures. So it brought us into a whole new world, and we had to learn our way through that. So she is currently seizure-free, but has only been now for about 4 months seizure-free. So yeah, we've definitely had some struggles along the way.
Right. Okay. So we've all heard the phrase, it takes a village to raise a child, and the same can be said for the health and well-being of a child with epilepsy. Ideally, the parents, the child, the neurologist, the pediatrician, the school nurse, the teacher, and often many others should work together as a team to promote the child's health. In practice, however, this doesn't always happen. Important decisions may be made unilaterally or without appropriate input from each team member. And ineffective communication between professionals can lead to frustration and, more importantly, negative impacts on the child's health. In this session, we're going to discuss how shared decision-making, collaboration, and communication can help to avoid some of these common pitfalls and improve health outcomes. So let's start by discussing the concept of shared decision-making. The SHARE approach, developed by the Agency for Healthcare Research and Quality, provides a helpful framework for how physicians can support shared decision-making. So in this approach, S stands for seek your patient's participation. H is for help your patients explore and compare treatment options. A is for assess your patient's values and preferences. R stands for reach a decision with your patient. And E is for evaluate your patient's decision. So the purpose of these steps and the overall concept of shared decision-making is to engage patients and families in their healthcare decisions through meaningful dialogue about the benefits, harms, and risks of their healthcare options and what matters most to them. So that's really important. So Dr. Khalil and Nicole, can each of you share an example from your experience where the principles of shared decision-making were not followed and another where they were, and kind of compare the outcomes of each situation? Dr. Khalil, would you like to go first?
Sure. So basically, when I look at shared decision making, I think building a good relationship with the parents and the patient, this is the most important thing in the clinical encounter, because this would give them kind of like, they will feel more comfortable to share their concerns and even to express what do they want. So when I look at the shared decision, my approach to it, I remember like I have to introduce a choice, discuss the options, then discuss the decision and give them a chance to kind of like digest and think about all these options and choices. The model, basically, if you think about it, it is basically the most important thing is what matters the most for the parents and patients. This is the question that I ask all the time for my patients and their parents, because I'll be surprised by the answers as a doctor and as a mother. So what matters for me doesn't mean that it matters the most for the parents, and vice versa. So I'll give you two scenarios here from my experience with very similar epilepsy cases. The first one was a 5-year-old child who came into me with, of course, seizures, focal seizures. Then we did all the investigations and we diagnosed him with occipital lobe epilepsy, and it was very localized to the right side. So from the beginning, these parents were heavily involved in taking decision. And so we discussed with them from the beginning the options. What does focal epilepsy means? What's usually the treatment plan for focal epilepsy? So we have discussed all the options for anti-seizure medication, side effect profile for each one. And even we talked about epilepsy surgery down the road, and even maybe he might not be a surgical candidate, he might end up with VNS or other things. So from the beginning, there was a clear kind of like discussion about options and everything, and they were heavily involved in taking decision. This patient, they picked the best kind of like medication, so we started Keppra. Then unfortunately, he didn't respond to Keppra, so we had to add triliptal. And unfortunately, he continued to have seizures. But here is the thing, because we have discussed surgical option from the beginning with them, and they had asked all their questions, they did their own search, so we were all on the same page. So this patient ended up with surgical epilepsy evaluation and ended up with surgery actually at Helen DeVos. In just like in less than 1 year of diagnosis, and he has been seizure free now for 2 years. He's doing great at school, and he's doing really great overall. On the other hand, I had a patient, the same exact diagnosis. She was 10-year-old, unfortunately also diagnosed with right occipital lobe seizure. But here is the situation with this kiddo. Her parents are divorced, so she lives 50% kind of like shared custody. And she used to come all the time to the office with her mom only, a little like sometimes with dad also involved. But what happened with her, again, we discussed all the options. We discussed focal epilepsy, like the treatment, option plans, everything. But here is what I feel like maybe like a mistake we did on our part. We didn't ask how much the stepmother and stepfather involved in shared decisions. And apparently they do have a heavy role, like they were really involved in taking decisions. To the point was that stepmother was a big fan of homeopathic medicine, and she likes to try remedies. So she stopped the anti-seizure medication without talking to us, and ended up the patient in status epilepticus multiple times to ER. This patient eventually kind of like, we talked about other medication, we added also other medication didn't work. Then finally we did a surgical evaluation and also underwent a surgery with good result, but it took 4 years to have this. And I feel it is on me that I should have asked from the beginning who is involved heavily in her care. We finally reached like a good kind of like to be everyone on the same page when I asked for family meeting, that the 4 parents are in the same visit, or like do like a Zoom meeting. And actually telemedicine helped a lot with this case. I used to do telemedicine even before the pandemic, where we had everyone on Zoom meeting to discuss the options. But here's 2 scenarios where the first one took less than 1 year and the other one took 4 years.
Those are great examples. Nicole?
Yeah, so those were great examples. Thank you, Dr. Khalil.
Yeah, sure.
So our experience was working with the doctor's office. After 3 years, multiple medications, we tried the modified Atkins, and she had a very serious drug reaction to one of the medications, and it caused a lot of strife between us and the doctor's office, unfortunately, because the doctor's office didn't believe it was the medication causing the reaction, and we did, and we were proved right. But it just caused this broken relationship with the doctor's office. So as a result of that, I continued to do research and look for options and alternatives. And I started our daughter on a supplement without talking to the doctor first. And I know that that was wrong, but we had great results. She was seizure free. There were no signs on her EEG. And it took me about 6 months before I told the doctor about it. And of course, the reaction was not positive. And it again just further broke down that relationship. So it is so important to have a trusted relationship with your doctor. And I so respect that. But we had had such a bad experience. So that did not go well with the doctor, and our relationship with the doctor. It did prove well for my daughter in that period of time. That was an example of where it was not followed. And it isn't something I would repeat. This last year, we, in the same practice, have a new doctor assigned to us. And from the get-go, I was very upfront and very direct with them and shared all of the information. And it has gone so much better. It's a shared exchange of ideas and communication. And she had gone from a point in time where she was about 4 years seizure-free. And the prior doctor had forced us to start to wean because she was doing so well, and that caused seizures again. So working with the current doctor, we went back to the level that, in discussion, no other changes were made without that discussion. We went back to the level that she was at previously, and that's what's brought us back to seizure freedom. So yeah, I definitely am an advocate for that trusted relationship with your doctor. And if you're not finding that, the hard part is once you start down a path with an office, changing to a different office also causes, and I know we'll talk about that a little bit later as well. But that definitely, not having that trusted relationship caused us a lot of hardship. Whereas having the trusted relationship is much better. And I'm a strong advocate for that.
Right. So Dr. Khalil, when looking at the doctor-patient relationship and parent relationship as well, as it relates to epilepsy, what do you see as the most important responsibilities of the doctor and the most important responsibilities of the parent and child?
So yeah, so I feel like there's a lot of shared things that both they can kind of like apply to both. So when you're talking about most important doctors' responsibilities, first of all, like physician willingness to listen. Our job here is to listen. We signed up for that, you know. So I hate like when a doctor is in a rush. As a mother, now I'm talking as a mother, when I take my kids and I feel the doctor is just in a hurry, he's not willing to listen to me, how I'm gonna express what bothers me the most, you know, or what I want from this encounter. So willingness to listen is very, very important. And you have, as a doctor, to show your parents that you are really listening with good eye contact, not just like sitting typing the notes and they're talking to you. Like to understand also their body language, you know. The other thing is also honesty from both sides, I would say, not just from the doctor. From the beginning, you have to be direct, clear, and honest with your patient. If there is an epilepsy syndrome that unfortunately carries a guarded prognosis, from the beginning, you have to tell them. From the beginning, you have to share the options, the treatment options, other things with them. The other thing also is good communication. I always believe that good communication, we'll talk more about it, leads to good coordination of care and good results down the road. The other thing is respect, respect, respect. I have to respect my patients, my parent, the patient's parents, respect their wishes, respect what do they want, and the same from patient. So patient's responsibility is kind of like the same thing. Communication, communication, communication. I'm not gonna get frustrated if you keep calling my office, letting me know that, oh, she had breakthrough seizure, or he has breakthrough seizure. As a matter of fact, like in our MSU, we encourage that a lot. For example, through portal, just, it's okay, give me updates. I like the updates. I'm here to hear you. So communication is very important. Again, trust, as Nicole mentioned, you need that trust between both, that I trust the parents and the patient, and they do trust me. Because having trust, believe me, it's like the main thing in any relationship, not just like doctor-patient relationship. And also, I want the patients not to be ashamed from asking questions. It's your child. It's like you are the best advocate for your child. You know the best for your child, not me. You know her or him the best. So all these things, I feel those are responsibilities on the doctor and the parents. I don't know if Nicole has
Right.
more to add. Yeah.
Yeah, Nicole, from the parent's perspective, what responsibilities kind of stand out as most important to
Yeah.
you for all the team members?
100% agree with Dr. Khalil that communication, trust, 100%, 110% on that. That is important. I'd like to add, I think one of the things that the doctors, the part of their role is as a mentor to this family that comes in when you're first diagnosed with this, because this is a world that we don't know anything about, where the doctors have spent their lives studying, or their adult lives studying and planning for this. We didn't know anything, and we really needed someone to guide us through that for many different capacities, like a lot of what Dr. Fain talked about as far as quality of life and the whole picture, not just the medication, but the whole picture around that. So mentorship, I think, is so important with the families. As a parent, being an advocate, but being a partner with the doctor and taking that approach with the doctor, I think that is also so very important. And coming and asking questions. And I know the foundation has a great resource of the different types of questions and information to bring to appointments. I encourage people to go look for that. I've also, through the years of experience, come up with my own list of questions, which I think has been a valuable tool, and I'm happy to share that with anyone who participates with our parent calls that we have on Tuesday nights. But I just think it's so important to be that advocate and have those questions and come ready to ask those and be prepared. And then for the patient, for the child, as they're ready and starting to take that on, I think that is so important, like Dr. Fain talked about. I haven't seen it happen yet as much for my daughter, and she is capable. This is the only situation, illness that she has. She otherwise, I hate to use the word normal, but she's outside of having her seizures, she has no other issues. So she's fully capable of taking that on. So I think it's important to help her feel control or feel empowered and to feel ready to step into that. Right now, she's still scared and not ready to do that. And she's almost 16. So my focus right now is really helping her and working towards that with her. So I think those are some really important things for the three.
Great, great, thank you. So timely and effective communication between the child's neurologist or epileptologist and the pediatrician is essential. Dr. Khalil, can you talk about some of the dangers of neurologists and pediatricians not being on the same page?
Yeah, absolutely. So as I said before, the most important thing, the first step is communication. We need good communication between the primary care physician and the subspecialty care physician in any disease, not just epilepsy, right? And the good communication leads to good coordination of care. And once you have that good coordination of care, you have a good outcome in general. So absolutely, lack of good communication and coordination can basically lead to catastrophic outcome and sometimes mortality and more morbidity. So for example, delaying in diagnoses, for example, like medication interaction, and we see that a lot where our patients, for example, on an epilepsy medication, that the primary care physician start another medication that would affect the level of the anti-seizure medication. And then here we go, the patient in ER seizing. So the other thing is also very dangerous is mixed messages that might affect the treatment plan and also affect that trust relationship that the parents would go, oh gosh, the doctor told me something and the neurologist or the epileptologist told me something. Who should I believe? This is where the trust starts like not there. The other thing is, I'll give you like an example also, like what Dr. Fain said about like comorbidities. The primary care physician should be aware of the comorbidities that come with epilepsy. For instance, like ADHD, anxiety, mood disorder, all of that. So they should be also on the same page with us that you should, as a primary care physician, to address those as much as we do. For example, I'll give you like a story. A patient who came into me, I diagnosed him with epilepsy and he had ADHD and he was on ADHD medication. His primary care physician, he decided to take him off the ADHD medication because he felt that he can't give ADHD medication to a patient with epilepsy. And this patient, his performance at school started going downhill, not because of the seizure, because of the comorbidities, the ADHD. This is an example where I wish that doctor like just texted me or called me or sent me a message through EMR asking, oh, can I continue the ADHD medication? Or at least read my note that I sent to him. So these kind of like, even if they are like look small to us, but they are big for patients and parents, you know? So it's very, very important to have good communication, to have a good coordination of care and good outcome.
Okay, great. And we're going to actually skip ahead just based on the time a little bit here. Nicole, can you talk about the systems that you found to be most helpful in storing and organizing and tracking the large amount of information accumulated in caring for a child with epilepsy? And how has that helped you to advocate for the child and communicate with providers?
Absolutely. So one of the things I did when this first started for us was, and I did this on my own, but there is information out there. And again, through the foundation, there's information out there about starting a notebook. So I have a notebook. And I started tracking everything. And when I started this notebook, I thought, you know, I would never fill it. Well, it's completely filled now, and I've had to start a second one. But I used this for tracking all of her seizures, all the medications and the medication changes. And then the seizures, I also track what had happened around that. What did she eat? How did she sleep the night before? Did I notice anything? Were there any other symptoms, anything precursor to that? So I've tracked that all in there, and that has helped me tremendously in working with the doctor. The other thing I did was I took a calendar, a free calendar I got from the credit union, and I track all of her seizures on a calendar format. And this is a good visual for me, especially as she moved in towards puberty, in tracking any kind of patterns that I would see, which I did start to see patterns, and I didn't even realize that they were happening until I looked at the visual of this calendar. So that was instrumental for me. I also keep a full binder of all of her medical appointments and all of the documentation, all of the test results, everything in there, and I keep that organized there. And then I use my phone, and I use the notes section of my phone when I go to appointments to track things like her weight, heart rate, different things, and then whatever the doctor we talk about. So I keep that in my phone, so I always have that with me if I go to another appointment, that I've got that information as well. So those things have helped me tremendously in working with the doctors.
Okay, and Dr. Khalil, from your perspective, what are the benefits and possibly any challenges with having a parent who has a lot of information that they bring with them on their patients or their child's history?
Let me tell you that I love it when a mom or father walk in with a binder. So I really love it. So especially when we have like a new patient or someone transferring care from different state or different doctor, I just love it, because it is amazing to have everything just summarized, and then I can go through it all. And because I really want to understand the case from the beginning, you know, I really want to take a detailed history. Parents try their best to give us all the history, but having things written, it's very important. Now, challenges, as I said, I love it. I personally love it. So I don't think of any. Maybe some people, they feel overwhelmed with a lot of information in their hands. Other challenges, maybe some parents, they have expectation that I'm going to review that binder in the same encounter, like same day, which is really hard. But I personally love it. I kind of like appreciate the time they put into these binders to put it and organize everything as parents. I know it's not an easy job to do that.
Great.
So
great. Yeah, and there are, you just have to find a system that works for you as a parent. Some people it's a binder, some people it's a notebook, maybe an app or something like that, but or a combination of things. But having that organized information is essential. So while this may not be true during the COVID-19 pandemic, children often spend as much time or more time with their teachers as they do with their parents. With this in mind, teachers, school nurses, and other school staff can play a very important role in both managing the student's seizures and providing information that can be instrumental in diagnostic and treatment decisions. Can each of you give an example of how a school professional helped to bring about a positive health outcome for a student with epilepsy, and talk a little bit about how you can engage school staff as active members of the healthcare team?
So yeah, sure. I believe school is a very kind of like, if you think about it, the child goes to school from 8 or 7:30, like the majority of the day is at school, except now in pandemic. So the teacher is the one who's like seeing him the most of the time, right? Most of the time he's in front of the teachers. So I do believe that school is, it's an important part of epilepsy management. That's why I make it clear for the parents from the beginning. I'm more than happy to talk to the school nurse. And I had a lot of cases where the school nurse just called me or texted me, where I had really a good discussion with the nurses, what to watch for, how the seizure semiology, it's important to discuss the seizure semiology and how the seizure looks like, because you don't want the teacher start kind of like, if the patient did even like any small abnormal movement, think of it that it's a seizure, then call the parents, hey, come pick up your child, he has a seizure. We don't want that, right? We don't want to interfere with their learning. So basically, I like to discuss seizure semiology with the nurses, and also we discuss with them seizure action plan, what to do if seizures happens at school. And we provide them with a seizure action plan. Nurses and teachers were very helpful in many cases where I really needed to talk to the teacher to ask, what have you seen? How did the seizure looks like? And they were very helpful to me to reach a diagnosis and classify epilepsy and go forward with the treatment plan.
Great. Nicole?
Yes, so I've had some interesting experiences with teachers, some really good, very positive, and then also some challenging, with my daughter being in high school now and changing in different classes. From the time she was in second grade when this started, and so from the very beginning, I've been very open and working with the teachers and the schools and the families, especially when she was in elementary school, and working with the families to try and address that. In the high school level, the teachers, I understand from their standpoint, and I've also worked very closely with the school nurse, they have a lot on their plate these days. There's a lot of different health things that they almost have to be like a pseudo medical person as well, or skilled or knowledgeable in so many different areas. It isn't just epilepsy, I understand that. But there's some basic things in how you deal with a student who has a situation, and that I wish that they could keep their eyes open for. I had one teacher where my daughter had a seizure in class, and she was sitting in a chair, thankfully, and he just sat and watched, and the whole class just sat and watched. And then when class got over, and she didn't know what had happened, class got over, and he pulled her aside and said, did you know you had a seizure in class? And she was mortified, and she said no. And he said, well, I think you need to go to the office. So he sent her to walk to the office by herself. And we know it takes time for recovery and for the cognitive and just all these things. I was so concerned about her safety and her emotional well-being in that situation. So there's a lot that we draw and ask our teachers to do. And I understand and realize that, but we really need them to do that. And I said to the teacher, when I did talk to him, I said, think about what a message you sent to the rest of the students in the class about a person having a seizure. You just basically ignored it instead of teaching people how to respond with compassion and are you okay? You're safe. As they come out of it, there's certain things, or looking it up and having someone escort her or having someone be a buddy for her, or there's so many things we could have done in that situation. And I'm hopeful after talking with them that if he ever encounters it again, that he might do that. But yeah, there's certainly challenges and room for growth there. I think it's still one of those situations that people just don't talk about it enough, and they're not comfortable because it is scary. It looks scary to people, and I understand that, but those are some of the examples I've had with teachers. And then I've had some really good ones too.
And that's where, the parent and family preferences and the child with epilepsy, their preferences as to how you deal with a seizure. How do you want the teacher to respond? How do you want the other students to respond? Some people might say, yeah, go ahead, just carry on without me. Don't pay any attention. Just, I'll be fine. Other kids, would like reassurance. Other kids would like, a more, a different response and would like to have a designated place to recover and all of those types of things. So it really is just a matter of having that conversation with the school staff and letting them know what your preferences are.
Yeah, my daughter, unfortunately, in elementary school was bullied significantly and experienced a lot of exclusion as a result of her seizures, even though we were very open with all the families. So that has led her to be much more sensitive and to be much more closed about her condition, unfortunately.
So Michigan is a large state with many geographically remote areas. And one of the silver linings of the COVID-19 pandemic is that the use of telemedicine has expanded exponentially. So can each of you just briefly talk about your experiences with telemedicine and how this may be able to help with communication and shared decision-making both now and into the future?
Yeah, so I used to do telemedicine even before the pandemic, as I have patients up north where it's much easier just to do telemedicine with them. But definitely with this pandemic, initially we were like 100% telemedicine visits, then we kind of like gradually now back to the normal face-to-face. Telemedicine is a great tool because if you have a patient who lives like 4 hours from here, and it's like, and just like an epilepsy follow-up, you just want to make sure things are okay, it's much easier to do it because like imagine like the impact of epilepsy is not just on the patient, it's also on parents and the whole family. Imagine how parents need to take a lot of time off from their work, from their life, just to bring their child for an appointment. So definitely it helped a lot. And also having telemedicine, a lot of cases where I need I felt it's much easier to see patients, for example, who needed more appointments. For example, okay, I'll see you in 2 weeks. It was much easier to kind of like schedule that telemedicine in 2 weeks because we have availability and it's much easier just to do. We were happy that the insurances relaxed all the rules about the telemedicine. We hope it continues, but we will see after the pandemic how it goes.
And just as a follow-up to that, have you had any experiences with using telemedicine to have a joint appointment with a pediatrician and neurologist, or with a pediatric neurologist and adult neurologist in transition? And I assume there's some billing barriers to that?
Correct. Yes. The main issue is billing barrier. Maybe you were with us on the webinar we did the other day, as I have done it with PM&R physicians and psychiatry physicians, but one of us was able to bill, unfortunately. So, which I understand, but we have done it for the patients because those patients, we really needed to be all on the same meeting. And toward the end, patients come first, you know. Patient comes first. So, but unfortunately, we haven't done it more in kind of like a coordinated way where with multiple providers are on the same Zoom. We have done it with our nurses. So basically my epilepsy nurse or epilepsy medical assistant coordinator, especially if there is an epilepsy surgical case and it needs a lot of coordination, definitely my MA and my nurse will be with me on the same Zoom meeting with patients.
Okay, great. Nicole, have you had any experience with telemedicine?
Just very limited, and I think I wasn't aware of some of the insurance restrictions that there were in place before, but that makes it clear. I mean, I found that out recently, but that makes it much clearer as to why when I had requested some things in the past, we weren't able to do that. Yeah. We had one recently with her neurologist, and it went very well. Achieved what we needed to do, and we actually were able to do it while we were on vacation, which was we were able to get away for a week, so that worked out very well. We were able to keep our appointment and still, because we live a distance from where her doctor is, so yeah, that has been a good experience, and I think it meets the need. I would like to do more of it, and I would like to do, I said earlier that she doesn't have any other health conditions, which is slightly incorrect, because she has got drug-induced lupus, which now she has systemic lupus. So we've seen a rheumatologist as well. So at some point through one of the foundation meetings, it became clear I needed to talk to a rheumatologist or immunologist, I guess, if that's the right way to say it, someone about immunotherapies, and to talk with immunotherapies or neurologist and the rheumatologist, and I wanted to coordinate all of that, and Zoom and telemed would have been so beneficial, but I was never able to get that meeting. So I look forward to in the future, hopefully being able to do more of that.
Maybe that's something we can advocate for.
Yeah, the pandemic has definitely changed a lot for so many things. Yeah,
right,
for sure.
Okay, so I think based on the time, we're going to go ahead and open it up for questions. We do have some questions, and I'm not entirely sure if these are new questions or if they're left over from the last session, but Dr. Khalil, if there are some left over from the last session, perhaps you could address those as well. So let's see what we've got here. Okay. Someone asked if schools go completely online, how much can spending a long amount of time online impact seizures? Any thoughts on that about spending a lot of screen time for, I mean, I imagine for potentially some people with photosensitive epilepsy,
Exactly.
a problem, but what are your thoughts, Dr.
Yeah, so basically it depends on their epilepsy classification and what type of epilepsy. As you said, photosensitive definitely can sometimes cause increase or decrease, sorry, in the seizure threshold. But think about it, the photosensitive that we are talking about is not the static screen time. It's more of like really kind of like on and off flashing light. Those are the main one, or strobe light, that those are the main one that can cause a breakthrough seizure. So I would say in this case, benefits would outweigh risk, right? Because you want your child to get a good teaching, you know, and finish their school and to perform well. So I would say no issues if her seizure or his seizure they are not photosensitive.
Okay. So it does look like the remainder of questions were kind of left over from the last one. So, and Nicole, you can certainly feel free to jump in for any of these as well. Let's see. Oh, is schools open? How would I deal with bus transportation? My son has the rescue medication, but will the bus drivers need training and need to carry it on a regular bus?
So it depends on the school, unfortunately. So some schools are willing to do so, and some of them are not. But as a bus driver, he needs, the parents, they need to communicate that our child has epilepsy with the school, of course, nurse, teacher, and bus driver should know about it. So if the patient end up with a seizure, so the bus driver should know what to do, like at least like pull aside, put him on his side, like the seizure first aid at least, even if he doesn't carry the diastat or Nazilam with him. At least seizure first aid should be aware of that, as in any other emergency, you know. It's important to discuss that with the bus driver, and I always tell the parents to do so.
Yeah, and Cindy Hanford, who's our nurse and advocate, will go in and do training specifically for bus drivers upon request. And we've had situations too where families will request a paraprofessional be on the bus and be trained in rescue medication administration. So,
and again, it depends on the epilepsy. If someone who's having like refractory epilepsy, seizing all the time, yeah, it depends really on the seizure control and the epilepsy type.
okay. Can you explain what generalized epileptiform discharges are and what it means when they see that along with slowing? That's kind of a EEG question.
Yeah, sure. So when we deal with epilepsy, here is the thing. Epilepsy is classified to two major types. We call it focal epilepsy and generalized epilepsy, okay? And when we classify epilepsy, it's not just based on the EEG. When we classify epilepsy, we take into consideration age of onset, seizure semiology or the seizure description, EEG data, and comorbidities. Those are the four things we depend on to classify the epilepsy. So from the EEG standpoint, when we see generalized epileptiform discharges, this means that the epilepsy classification is most likely generalized epilepsy. I still need the seizure semiology, age of onset, and comorbidity to come up with an epilepsy syndrome. Now, generalized spike slow wave, again, this is generalized epilepsy. The other thing is, this is what we call the interictal abnormality, which means those are the abnormalities that happen between the seizures. The other thing we take a look at and we really care about is the background of the EEG, which means is it slow or normal background? So when you have a slowing of the background, in addition to generalized spike and slow wave discharges, this would shift your way of thinking to different epilepsy syndromes. So I don't know, as I said, I don't know what the seizure semiology in your child, the one who asked, or the comorbidities or the age. Because if, for example, there's like generalized spike and slow wave, and for example, it's 1.5 hertz to 2.5 hertz, and the background is very, very slow, and the patient is developmentally is kind of like he's regressing or she's regressing, this can be one of the epileptic encephalopathies like Lennox-Gastaut syndrome or other things. So the importance of the interictal abnormalities, we take it with the background to help us classify the epilepsy.
Okay, great.
I hope I answered the question.
Yeah, that was great. Nicole, we have a question for you. My daughter is currently 9 and was diagnosed with epilepsy at the age of 6. Looking back, was there anything you would do differently when it comes to her schooling or epilepsy care?
I guess I would talk more to the teachers and make sure that they have the information, and talk also not just about how to respond with emergency situation or epilepsy care, but overall just the social, emotional health of her in the class, and working with the class and working with her to develop those relationships. I think that is so important. Having a buddy with her and helping her feel confident. And that's one of the things, again, as a result of the bullying, that's one of my goals, is helping her feel confident and comfortable with who she is as a whole person, to then seek out and look for those buddies. I think that's really important.
In terms of her epilepsy care, anything you would do differently in that regard?
No, I think, in hindsight, the relationship with the doctor, like I mentioned, and not bringing things forward, that probably I would change that. But overall, for her epilepsy care, I feel like I've been a good advocate for her.
Great. All right. Well, it is noon, so we are going to transition to our next section. So thank you so much, Dr. Khalil and Nicole, for a really enlightening discussion. And now up next, we have Dr. Nazanin Mahmood, who's a pediatric epileptologist from Children's Hospital of Michigan. And she will be talking about seizure management in the school. So welcome, Dr. Mahmood. I can see you, and yep. So if you want to just hit share screen, then you'll be able to share your PowerPoint with the audience.
All right. Hello, everybody.
Okay, we're all set. You can see it.
And you can see me.
We can see you, we can hear you, and we can see the PowerPoint. So.
Okay, great. All right. Well, it's great to be here, and to try and get families prepared for school in whatever shape and form it takes in the fall. Thank you, Russ and Epilepsy Foundation, for having me here. So seizure management in the school is the topic at hand. How do I advance these? Oh, I just click it, I think. Okay, so the outline of topics that we're going to discuss is seizure action plans. Epilepsy Foundation has a almost universal looking plan, but I'll show you some other ones too. Common challenges in implementing seizure action plans, the available types of rescue medications, and some of the newer ones and some old ones, when to call 911 for a student, because the point of having a seizure action plan is to hopefully have a few less trips to the ER. But sometimes you need to call 911 and have evaluation. Seizure aftercare, and seizure tracking and documentation, which can be also participated in by educators. So, okay. So children with epilepsy at school and seizure action plans. So this is not an uncommon topic, and everybody should feel comfortable and it's your right to advocate for your child. According to the CDC, 3.4 million people in the US have active epilepsy. 3 million adults and 470,000 children with epilepsy. So since there's 0.6% of children aged 0 to 17 years of age have this active epilepsy, in a school of 1,000 children, 6 students would have epilepsy. So this is something they should be prepared to accommodate and have discussions about, make preparations. Seizure action plan is needed for all students with active epilepsy to provide essential information to the school staff, which needs this to help a student with seizures. It provides information on first aid, parent health care, parent and healthcare contacts, and delineates the child's medications. There's a CDC study that has shown that children aged 6 to 17 years of age with epilepsy were more likely to miss 11 or more days of the school year. So they, as a result, have more likely to have difficulties in school, use special education services, and have some form of activity limitations. Thus, when an IEP and 504 plan is present, seizure action plan should be included as a component. So just to briefly cover IEPs and 504 plans for families that may be new to all of this. IEP is the individual educational plan. It's implemented by schools after testing and parental sign-off for students who need special education and related services due to their learning disabilities. And this is in order to make educational progress. This can include before and after school activities, and in order for rescue medication for seizures. A 504 plan was originally put in place through the Rehabilitation Act of 1973. It provides students with disabilities who do not qualify for special education or related services with accommodations and modifications, as well as other services. To provide, it also does, to have this, to qualify, you have to have a physical or mental impairment that substantially limits one major life activity. So this is intentionally broad, I think, and those that formulated this, any impairments in reading, writing, walking, seeing, breathing, self-care, math calculations, hearing, learning, working, performing manual tasks. So, oops, sorry, what did I do? I'll go back. Okay, so not all children with epilepsy will qualify for 504 plan. So they may qualify as other health impaired, and that can also be incorporated into the IEP plan if the impairment affects academic performance. So again, when an IEP and 504 plan is present, the seizure action plan should be a component and come up for yearly review as part of that. So certain benefits are present to having a seizure action plan. It's legally applicable under the IDEA, Individuals with Disabilities in Education Act, and also under the Americans with Disabilities Act legislation. It applies to schools and daycare centers, which cannot refuse due to enrolling a child with seizure history. It can help prevent emergencies and help caregivers and school staff know what to do in the event of an emergency. It can help parents and children from being fearful and stressed, thereby enjoying better their life, having a more fulfilling life. And what you do with it is you review and complete your plan with your doctor. can keep a copy with you, copies with school, nurses and staff, camp counselors, other caregivers, after school caregivers. And it medication can be dosed for seizure lasting a certain duration, or for clustering of seizures, such as 2 or more seizures without recovery in between. So we talked about the benefits, the necessity part of having a seizure a rescue medication, not just a seizure action plan. The longer a seizure lasts, the harder it is to stop, and it may result in status epilepticus, where recovery is not happening from a seizure, is continuing on, which would require hospitalization, IV medications, intubation, a lot of invasive things. And the longer recovery, not having a rescue medication in use also creates a longer recovery time from longer seizures. It prevents, hopefully, unnecessary transport to emergency rooms and additional cost, with all the loopholes in our healthcare system. And hopefully it prevents any kind of hypoxic injury to brain tissues, such as temporal lobes with increased scarring, and thereby chances for lifelong seizures. I am typically dosing seizure medications with any kind of convulsive seizure at 3 minutes these days, because we don't want to get into any duration of hypoxia. So steps in creating and implementing a seizure action plan. So you would first ask the school for any particular school forms that they have. They may be very, regimented with their forms, or you can use a generic form with, such as that from the Epilepsy Foundation or AEP as well. Second step may be to go over details of the form with your neurologist and pediatrician first. Pediatrician can do this as well. So you would select the best option for seizure rescue medications. You would, determine and document when EMS should be called. And this is something doctors should take the time, or if depending on the setup of their clinic, the nurses should take the time. Some healthcare providers should take the time to initially go over this, because in our clinics, we formulate a plan and we keep it on file. Don't consider it too time intensive for your doctor or their staff to do with you. Seizure action plan should be used to facilitate a discussion between the school and the family. So instead of just turning the forms in, they should actually have a time to sit down, perhaps as part of the IEP meeting or separately, to sit down and go over the seizure action plan. Parents can inform details to the school of what seizure and child's history entails. Some children will have auras, or factors that contribute to decreased seizure threshold, and other history that may help them take care of your child. Parents should get to know what resources and personnel the school has, any nurses, social workers, or unlicensed assistive personnel. So what you can realistically expect from your school. Get to know any pertinent school policies as well, such as, if do they have to call EMS and have an evaluation, if seizure action plan has to be put in use. Some districts may have that kind of regulation. Parental work and childcare circumstances should be known to the school. And maybe there's a grandparent or other family member nearby that would be, on the list of emergency contacts. And parents, thereafter, I should expect to advocate for your child. People are afraid of what they're not familiar with. it's not necessarily that they're, trying to be curt and, not take the time to take care of your child, but unfamiliarity drives a lot of barriers. So you may ask to incorporate district school nurses in the meeting. So, only 54% of schools in Michigan have any nursing care. So there is in most places a district nurse, and that person could be incorporated for the training of personnel and for formulating behavioral plans. So that at least is a resource that can be tapped. A special education director for the IEP and 504 aspects of your child's care, including behavioral plans for any emotional impairments, any difficulties they're having at the time, managing their epilepsy or their diagnosis. Possible barriers you can expect, that they may not have licensed personnel to give the seizure medication, but it is not a necessity. Then they are not liable. They are obligated by law in terms of taking public funding to actually provide for your child. So that is the bigger duty upon them. So you can ask for education of pertinent staff to be mandated. There are 1.5-hour modules, easily accessible. I didn't see any cost associated through Epilepsy Foundation and other organizations. And that statistic, again, that 54% of Michigan schools don't have access to school nursing services, but there are other personnel that they should have take on that role. They may say they have no one to watch a student during recovery period. So parents can plan ahead with their IEP and 504 and seizure action plan, all rolled into one. They should delegate 4 people who would be readily available that may be used. So there's no, misunderstanding there. They may have a concern for medication interactions and respiratory compromise with administration of medications. So I usually instruct people at home or at school to call EMS for evaluation for the first time a rescue medication is given. So because we don't know what exact effect or what level of sedation they're going to experience. Hopefully it's not too much. The research and statistics are in our favor, but still it's better to be safe and reassured in that regard. So, and there are typically no adverse effects with any of the seizure medications. There's theoretical, concerns with valproic acid, but I've had patients on that and they haven't had any additional sedation or difficulty tolerating seizure meds. There is a more likely over sedation if there's overlap of opioids, street drugs, or other CNS depressants, such as alcohol. So private daycares and schools may deny admission of a student or their seizure action plan because they're not taking public dollars. They are, or taxpayer dollars, they are in that loophole. So you may tap the Epilepsy Foundation or other organizations, other advocacy organizations for education and trying to mitigate those barriers for them. Or you may end up, worst comes to worst, changing schools or going to public institutions such as Head Start or Early On, which can't deny. So this is what, Epilepsy Foundation Seizure Action Plan looks like. I did compare other seizure action plans. It does seem to flow the best in terms of people grasping what types of seizures a child has and what the first aid should be, who the contacts are. Yeah, and you know, they should be aware of the daily seizure medications. Yeah, here's where healthcare providers would be listed. Aftercare for a seizure, rescue medications, and sometimes I do have a couple of different rescue medications on for a patient, clonazepam tablets and then diastat, you know, if it's a convulsive seizure. So all of that can be delineated, as well as when to call 911. So there are also a Spanish version of this, so that, you know, the Spanish-speaking parents can actually understand what they're putting in place for their child. There are seizure action plans through, this is the Child Neurology Foundation. It's a pretty decent one, in my opinion, as well. There's a form from the American Academy of Pediatrics. So those were the most prominent ones that I found. And some of these, as you can see, you can fill them out online and print them out. I think all of them are free and accessible. And, you know, to make any detailed parts of this easier and you know, more accurate, do go over it with your doctor. So challenges in implementing the seizure action plans. In the training of nurses and staff to handle seizure emergencies in districts that have school nurses, the ratio of student to nurses is among the worst, actually, in Michigan, among US states. There may be other frontline staff, such as secretaries, vice principals, you know, that have to be trained and ready. The training of other students for day-to-day interactions with students with epilepsy. You know, not only understanding and having kindness and empathy for this student with epilepsy, appreciating them as a person, but also includes how to coordinate teachers and staff when a seizure emergency arises, and, you know, you have to have a quiet, you know, environment with privacy to take care of the student. So that training probably also needs to be in place. Having rescue medications for seizure on hand, where they will be kept. Most of the you know, FDA approved versions are very easy to use. There are some that may require other ones we have used in the past that may require refrigeration, or, you know, the student may be carrying it with them. The staff have to know where and how to access it readily. Yeah, and recognizing when a seizure emergency is occurring, when there is prolonged altered consciousness, when there's a classroom full of 30 kids, or when a convulsive or generalized tonic-clonic seizure is occurring. It's not always the most apparent. Okay, so available rescue medications. I'm trying to see how I'm doing on time. Okay. So available rescue medications are the first one, which in Russ's questioning of the you know, attendees here, was the most commonly used, rectal diastat. So it's used for aborting breakthrough seizures and clusters and those already taking medication to control epilepsy. It's occasionally, we do use it for prolonged febrile seizures. It works through GABA mediation. Its most frequent side effect is somnolence, which is getting drowsy, and 9 to 17% can have some degree of respiratory depression, where they breathe shallower, perhaps slower. And this is part of the reason why I ask people to, you know, have 911 EMS evaluate them the first time they're giving it. Haven't had too much difficulty with this, but still it's a good idea. And less frequent adverse effects were dizziness, headache, pain, abdominal pain, nervousness, diarrhea, being unsteady on the feet. Yeah, I haven't had too much problem with paradoxical reactions. Yeah. So the procedure for giving this is to lay the student down, and depending on the convulsion, you may want to put something under their head to shield their head from, the floor or from them bumping it. You get the medication out. It's already pre-dialed. You cannot mess up and give, too much medication. It's dialed in by the pharmacist at what your doctor has dispensed or prescribed. I was trying to use the cursor here. You can push up on the cap with your thumb. There is a lubricating pouch. And hopefully by this time the room has been emptied of any other students and such. You turn the student on the side, you bend their top leg, and you separate the buttocks. You give it and count as you're giving the medication. You count 1, 2, 3 to as it's injected. In removing it, you also go slow, and pulling it out, count to 3, and then also holding the butt cheeks closed because you don't want the gel to come out. Also for 3 seconds. Sorry. Yeah, and then you time the seizure to see whether EMS needs to be called, if it's stopping the seizure. Diastat dosing, although it's FDA approved to the age of 2, we are have enough experience over the years dosing it to weight, and so we are dosing. And those of us who are epileptologists are probably more comfortable dosing based on weight. I have dosed 8-month-olds based on weight, and thankfully it's been safe in use. FDA guidelines say it's not to be used under 6 months of age, but no drug trials are present under 2 years of age. But that doesn't mean that medications can't be used without the drug trials present. There's a black box warning for use with concomitant opioids, which typically is not a problem in children. Teenagers we may have to give another thought to. It's not to be used more than 5 doses in a month, and not to be repeated in sooner than 5 days, because it does take time for it to clear from the body. We don't want to have too deep an effect with a second dose that's too early. And it usually stops seizures in about 5 to 10 minutes. Valtoco is the nasal form of diazepam. So it obtained approval just this year. It comes as 5 milligrams, 7.5 milligrams, and 10 milligram nasal sprays. So we can use a combination of those forms. It's been studied in patients 6 years old and above. 6 years old and above, and the second dose may be administered after 4 hours after the initial dose if another seizure arises. Yeah, and you're not supposed to use more than 2 doses in a single episode. There are, I'm going to try and go a little faster here, some contraindications like narrow angle glaucoma and any kind of hypersensitivity to benzos. But otherwise, it's pretty well tolerated, some of the same effects and maybe some nasal discomfort in addition to the rectal diazepam, somnolence and such. So you can dose it by weight. There are some drug maker warnings about serious adverse reactions. It's usually overlap with other CNS depressants, opioids. There are some reports of suicidal behavior and ideation after it's given. For most children, they're sedated. It's not causing that, vast majority. I don't think we're going to be using this in the very, very young, because there's something called gasping syndrome that can occur in newborns and low birth weight infants. Because there's a preservative called benzyl alcohol that can contribute to some respiratory issues in the very young. This does use something called intravale that loosens the connections in the mucosa of the nose temporarily and allows the Valtoco to be absorbed. Haven't found any, I did some literature searching, any reliable information that says there's any negative effects from this. So, but this is what took nasal diazepam so long, this barrier in the nose. There's Nasolam, which I have started using for patients, FDA approved benzodiazepine. So it's a nasal midazolam. For acute, it's approved for acute repetitive seizures in those 12 and older. That's because that's what the data is there for, but we use it for younger. The initial, and we don't use it for prolonged seizures as well. That's our primary use, as well as we can use it for clusters. There's an initial dose of 5 milligrams into one nostril, and a second 5 milligram can be given if seizures are not stopped after 10 minutes. If there's any kind of trouble breathing or excessive sedation after the first dose, not supposed to give the second. So contraindications, again, any kind of benzodiazepine, the glaucoma, and any hypersensitivity. There may be some nasal discomfort, some throat irritation, some runny nose, but those are not very major. They may be a little bit more densely impaired and sleepy for a while after, so shouldn't be doing anything that requires them to go down steps or anything dangerous. This is the dosing here, and as you can see, by weight, the dosing comes out to a point where I can dose 9 and 10-year-olds with Nasolam, the 5 milligrams. I cannot, split a nasal spray, and so I can't go use it for children younger than that or less weight than that. I am avoiding use in those with more serious cardiorespiratory issues, and there are some warnings about this. That's where my hesitation comes from. Maybe in a few years, when we have more experience, we will, like Diastat, we'll have a greater comfort level with the weight and more medically fragile children, but not as yet. There is a medication on the horizon. Hopefully it comes to fruition, called staccato alprazolam. It's commonly known as Xanax, and it has some, enhances neurotransmitter GABA again, creating a calming effect. Actually works for seizures when delivered nasally. Staccato system, where that name comes from, is the vaporizer that's part of this. So it's an inhaled version. I foresee that it's for people that know that a seizure is coming and can, cooperate with the inhalation part of it. There are phase 2A and 2B studies that have advanced it to the point where we can, we know that an average of 30 seconds is needed after the inhalation to, abort a seizure. They may be 30 seconds into the seizure, but typically it stops around there. Phase 3 studies were supposed to start this year. I suppose it may be delayed because of the pandemic. Other rescue medications like lorazepam intensol, this is a liquid. It's dispensed into the buccal mucosa inside the cheek. I don't consider it safe for generalized tonic-clonic seizures because of the increased saliva. I don't want anybody to have increased risk of aspiration. It needs refrigeration and cannot be dosed from a pre-sealed package. It's not a ready to dispense type of thing. And some schools and daycares may have regulations against this. There are very much in use clonazepam dissolving tabs. We've told people to use it by putting it between the lower lip and the gums. It is shown in studies to be effective in stopping 68% of seizures by 10 minutes, similar to Diastat, but I don't consider it as good an option in generalized tonic-clonic seizures because there is saliva pooling and jerking, and I have seen too many videos of it falling out of the patient's mouth. It horrifies me. So in that situation. So I use it more for myoclonic seizures, absence, and partial seizures where I know that it will stay in the mouth. So when to call 911? Am I running over, Russ?
Dr. Mahmoud, I'm gonna, just given the time, I want to make sure we have some time for
Sure.
Q&A. So we're gonna have about 5 minutes to go through our questions, but again, the PowerPoint will be made available after the fact and added to our website. So, so let me just open up the questions here. All right, so specific dosing question, and if you're not comfortable answering that, that's fine, but my child has Nasolam 5 milligrams and is 50 pounds, and is that okay for him? Didn't realize that there was an age recommendation related to that.
I'm trying to, so he has how much? I'm trying to go back to the chat here. Let me minimize this now. Go back to Zoom.
Yeah, and there was a related question about 5 milligrams for a 55-pound child. So I guess a couple of concerns about Nasolam dosing at 5 milligrams.
So are the questions off to the side here in the chat?
No, I don't believe you can see them. Yeah, one was asking about 5 milligrams for a 50-pound child, and another one 5 milligrams for a 55-pound child, and whether that is okay in terms of dosing guidelines.
I can check for you right quick. Seems a bit low, 5 milligrams for a 55-pound child, but let me check here. So 55 pounds, not kilograms, 55 pounds. Yeah, it is actually at the appropriate range, 5 milligrams, and has Nasolam 5 milligram and is 50 pounds. Is this okay? Yes, that is also the proper range.
Okay. So another question, curious to know if any of your patients have experienced compromised respiratory function, either ictally or post-ictally, with a switch to Nasolam from the intranasal midazolam using the atomizer.
Now I held off using the atomizer and intranasal midazolam, but now I am using it since it is in a more easily usable form, the Nasolam, and I'm holding my breath, you know, to see what comes. It's a bit of a learning curve yet, but no, none yet, and nor have I heard of it from my colleagues who've been using it maybe 6 months longer.
Okay. Is nasal M okay to have the child carry on them, like in their backpack or taken on field trips, along with some indication that they carry a rescue medication?
Yes, it is. They can carry it with them, and it doesn't require any refrigeration, anything like that. It's pretty easily dispensed.
Okay. Another child is going to do completely virtual learning for school this year. Do you think the seizure action plan is still necessary if that's going to be the case?
You can put it in place if they change gears at all, or have any kind of outing, in the middle of the year with social distancing. Doesn't hurt to have it there, but you may not be using it much.
Right, and certainly the teachers may be in a situation where they're seeing the child and maybe you're able to recognize, having had training and being aware of that child's seizure types, may be able to recognize seizures and at least alert the parents if that's the case. So yeah. I think there's value in that. Okay, let's see any other questions we have. Yeah, it looks like the rest of the questions right now are from previous sessions. So, so we are right about, the timing worked out just great. So we are ready to move on to our next session. So thank you so much, Dr. Mahmoud, for a really important discussion. And I know we're going to learn a lot more about these new rescue medications over the next year. So it'll be a topic that I'm sure we'll revisit. So thanks again.
Welcome.
And we'll move on to our next session.
Thank you.
So our final session is entitled Accommodations and Academic Supports, Approaches That Work. And our speakers are Dr. Angela DeBastos, who is a pediatric neuropsychologist from Beaumont Children's Hospital. And she's also a professional advisor for the Epilepsy Foundation of Michigan. We have Kimberly Tufnell, who's a retired director of special education and a person with epilepsy. And Becky Bigelow, who is a special education teacher and a parent of a child with epilepsy. Excellent, excellent. All right, well, thank you all so much for joining us. Can each of you just start by briefly introducing yourself and describing your experience with this particular topic? Dr. DeBastos, do you want to go first?
Sure. So as Russ shared, I'm a pediatric neuropsychologist and I work out of Beaumont Children's Hospital. So I conduct neuropsychological evaluations of children with a variety of neurological conditions, but the majority of my patients do have epilepsy.
Okay, great. Kimberly.
I am a former special ed director, but I started my career as a paraprofessional in a special education classroom and then went back and got my teaching degree. So I have been a special ed teacher, I've been a middle school principal, a superintendent, and so I've had the pleasure of working with many teams, brainstorming and researching and implementing academic supports and accommodations that will be effective, whether it's in my own classroom or being that support person, and sometimes having to be that person to talk to staff to remind them about the rules and regulations and the laws as far as implementing those accommodations in the classroom.
Great, great. So a wide range of experience to draw upon there. Becky.
Hi guys, my name is Becky Bigelow. Oh, sorry. I have a son, Eli, who's 12 and has epilepsy. He started having seizures when he was about 4 months old. As we've gone on our journey, we have developed some cognitive delays due to epilepsy. And I'm also fortunate enough to be a special education teacher in a resource room setting for students kindergarten through 5th grade. And I've been doing this for 8 years now, and I also am I also have unique circumstances in which I'm able to be Eli's case manager and special ed teacher, so I get to write his IEPs, which is kind of interesting. But because of the small school setting that we're in, that's how it works out. So that is the perspective that I'll bring to the table today.
Okay, great. Well, so students with epilepsy are at increased risk of cognitive challenges due to a number of factors, including the epilepsy itself, seizures and after effects of seizures, treatment side effects, and associated neurological conditions. So probably the most common of these include attention deficits, executive function disorders, reduced processing speed, and memory problems. So some students with epilepsy also have co-occurring autism or intellectual disability as well. So for this session, we're going to dive right into specific accommodations, academic supports, and resources and strategies that can help students with these cognitive challenges to succeed in school. So let's start by talking about attention. ADHD, whether it involves just inattention or both inattention and hyperactivity, is common in students with epilepsy. So what are some supports that you found to be most helpful for students with ADHD?
So for the attention component of it, those are actually usually pretty straightforward. So things like allowing them to have extended time to complete assignments, the distractibility that they may experience can result in it taking longer for them to finish things. Checking in with them after giving directions. This is one that I often recommend having it written slightly different than how it normally is. So often I'll see it written as, check in with student as needed, or if the child indicates that they need help. And the only thing that I struggle with that, and I think that some parents, it's obviously dependent on the child, but sometimes we don't know what we don't know. So sometimes it can be difficult to say, okay, well, we're going to rely on this child to go and ask for assistance when they may not realize they've missed something. So I typically will recommend that the teachers check in with the child anytime they give any instructions, and they can do so with other students around nearby as well, so that it's not singling out that one child who may need that extra support. Testing in a small group setting can be useful because it minimizes distractions. If you need the extra time, they may not be completely aware, or maybe less aware of the other students not finishing as quickly. And for older students, things like giving them copies of class notes, they're vulnerable to missing things, missing parts of what's been given to them through the instructions, so that can be useful. For the hyperactivity and impulsivity side of it, things like having them sit on a wiggle seat, giving them extra movement breaks, things of that sort can be useful for that. And then obviously there's always the question about medication. And I most certainly see lots of children and adolescents who are taking medication to support their attention and self-control skills. It's very common. But I do know that there are a lot of families who are pretty hesitant about taking that step, in particular because their children are already on a lot of medication sometimes, and they don't necessarily want to add something else to the mix. So the recommendation for whether that's really, something that would be helpful is often based upon the severity of the symptoms. And a lot of families will choose to try these other behavioral strategies first and then maybe implement a medication plan later.
But just to clarify, like use of stimulant medications for ADHD is not contraindicated for someone who has epilepsy and is on anti-seizure medications.
In general, no. I've seen many children who are on both.
Okay, great. Thank you. Kimberly.
Yeah, and those were really good accommodations and supports. I would just like to add, it's always good to have another set of materials and books at home because they tend to forget things. Also provide ample opportunities for movement, whether they're the ones running an errand or carrying some heavy books somewhere, just to get them up and moving. Also, it's important to have routines and lots of reminders. So a very structured classroom helps our kids. And I would also say alternative seating, if there can be maybe some stand-up desks or other areas, other places, other ways that our students can sit at their desk, that would be helpful as well. So that's what I think. And of course the fidgets.
Yeah, I remember one parent talking about their classroom having a stationary bike and it was charted. It would actually chart how far the class as a whole had journeyed throughout the year. So kids could just go right on that stationary bike when they wanted to, if they were feeling antsy or fidgety, and that was a really helpful tool as well.
That's great.
Becky.
Russ, you took one of mine. That's a big one that I've gained personal success with in my classroom. Not for, in a resource room setting, it's a little bit different. So I don't know how that would quite work in a gen ed setting, but I have a stationary bike in my room, and it works out very well for those kiddos. To piggyback off of what the other panelists said, I think that I've seen success in the classroom with, in the gen ed classroom with doing like a tape box on the floor in the back of the room, and students who have that hyperactivity, are allowed to pace and move and kneel and sit and, do whatever they feel they need to do, as long as they're kind of in that box that kind of contains some of their behaviors. For attention, I've had really good luck and success with like a callback signal with the teacher. So sometimes students don't even realize that they are, away from what they're supposed to be doing. And so even if it's just like you flash them a little thumbs up or a little card, some things like that. One of my favorite fidgets, because a lot of fidgets can be turned into toys, whether we want them to or not, but we've found a lot of success with putting Velcro underneath tables or desks, and that acts as a really good fidget for those kiddos with minimal distractions. So,
okay, great, a lot of great suggestions. Closely related to ADHD is executive function disorder, and executive functions include planning, organization, impulse control, flexible thinking, working memory, or the ability to hold multiple pieces of information and manage them at once in your head, task initiation, and other higher order thinking skills. So this is a wide range of functions, but can you discuss some approaches to managing these challenges in school?
So I think a lot of the things that we already talked about with the previous question apply for some of these as well. The nice thing is that a single accommodation can kind of address multiple issues at times. So I'll kind of focus on the planning and organization piece of it, because we didn't talk about that quite so much. In general, I have found that kids do better the more simple their life is. So the more simple their materials are, the fewer things they're having to carry back and forth. As Kimberly was saying, things like putting extra set of books in each classroom, or having them have some at home so they're not having to carry them back and forth, using a single binder versus multiple binders when it's feasible. I have a lot of my middle and high school students, I'll recommend that they utilize their technology. So for example, instead of keeping a paper planner, which may be difficult to keep track of and get everything written down quickly, I'll have them take photos of the board, or photos of notes that they can then, even set an alarm to remind themselves to look at later. On the more extreme side, if the patients, if the students need a little bit of extra support, it can also involve breaking tasks down for them so that they don't have to plan out the steps that are needed. And then I also wanted to just quickly mention that one of the other executive functions that is often a very big challenge is emotional regulation and frustration tolerance. So a lot of parents will feel like those behaviors are something completely separate, when often they're very much related. So the same system that helps us to stay focused and control our behavior also helps us control our emotions. So you'll see children who have these difficulties get angry much more quickly, more easily. And so they may need more breaks. They may need, once you figure out the triggers, you can kind of prevent that from happening. But in extreme cases, we might want to get social work involved and that sort of thing to kind of, come up with a plan to help them deal with those emotions when they're in the classroom setting.
Great. Kimberly?
And another thing that I was thinking about, even, and like the doctor said, so many of our accommodations and supports will work across the board with, one of the things that we have found very successful is check in, check out, having some separate person to check in with the student in the morning to see if they have all the materials that they need. And then at the end of the day, check out with them. Do you have all of your homework, etc. You can also do that with a buddy. I know when I was listening to Nicole say they didn't pair up her daughter with anyone, you know, after she had a seizure to walk down to the office, just having somebody that is in the classroom. Oftentimes our kids will take cues better from their peers than an adult. So I would recommend, you know, looking into GVSU's peer-to-peer program. I know that's typically for our students with autism, but that can be helpful across the board for any of our students, just to have somebody to pair up with, compare notes. But the check-in, check-out process is good. And then yes, absolutely some attentional breaks, because they need to be able to rest their brain, especially on that working memory and being able to recall and retrieve things. Because once they start having those cognitive difficulties because of their working memory, they're going to start fidgeting and they're going to start losing the attention again. So those are just a couple that I have found to be very successful.
Great, great. Becky.
Those were all amazing and things I had down too and was thinking of. The only other thing that I found very helpful with my own son for his working memory and task initiation, even though he's 12 and he can read, a visual schedule, not even a visual schedule, a written down schedule that he can follow helps him with where he's going, what he's supposed to be doing. And then also like changing that schedule if there's any changes that happen in the day, if you know that they're going to happen, you know, if there's special switch or there's a special assembly. I found that to, you know, to keep them in that pattern, it helps with some of those executive functioning skills.
Right. So one thing to just kind of follow up on the executive function, one of the things that can happen, because, you know, task initiation is a key executive function, and so often procrastination can become a problem, and then if you have difficulties with organizing and thinking of the sequence of how you're going to do things, you've procrastinated a project for a while. Now you're looking at this overwhelming project, and it can be just completely daunting to think about how am I even going to get started on this, and then how am I going to organize it. I guess what techniques might be helpful for that kind of procrastination and then being stuck with a daunting or overwhelming project?
I think that oftentimes it really just requires more oversight on the part of the parents and teachers and monitoring to ensure that things aren't being put off to the last minute. And then I think ultimately, obviously, the goal is that the student would, you know, which may be possible for some and not for others, that the student would develop that ability to do it themselves. So I often recommend that that the parents kind of sit down and have a discussion with their child. Okay, what do you think we should do first? And they might still have to do the next steps and explain the next steps, but to help them learn how to do that on their own. And I think the same thing can happen in a school setting. So for some kids who have that tendency to get extremely overwhelmed in their 504 plan or their IEP, it may be appropriate to have a recommendation of, you know, that someone sit down with them and plan ahead for larger projects and things like that.
Okay. Any other thoughts on that?
Yeah, we found it very helpful when teachers have, and we have done this, divided up the paper, whether you're just folding it, and then put the process by which you have to complete this project. So in the first frame, you're going to put, this is what you're going to do first, and then provide a checklist for the student to check that off. Okay, I've done this. Okay, now we're going to move to this. So when you're doing bigger projects, it's really important to chunk that for our kids so that they're not taking the whole thing all at once and thinking, I will never get this done. You can chunk it and then they can check off what they've done. They can also see their progress and feel good about what they've done as well.
Okay. All right, so let's move on to memory problems. Those are perhaps the most common cognitive complaint that we hear from people with epilepsy. What are some tools and strategies that you've found to be helpful for students with different types and different levels of memory dysfunction?
So oftentimes when parents come in and complain about memory, they're usually referring to working memory. So that's kind of fits into the other things that we've talked about, being able to keep track of what you're supposed to be doing, remember multi-step directions, things like But I also very often see difficulty with both retrieving information that has been learned as well as on the encoding side of it. So getting that information into the memory in the first place. On the retrieval side, obviously there's things that the parents can do at home, like flashcards and practicing retrieval, that sort of stuff. In the classroom, I've seen it be helpful for students to have things like word banks, or for in more extreme situations, they may need their tests to be adjusted so that it's more multiple choice versus open-ended free recall formats. But that's not always a realistic expectation. So that's why I would call that more of an extreme effort. And then on the encoding side, the strategy that I recommend most often, and this can be useful for kids who struggle with attention and also with processing speed, and that is to have the parents actually do some previewing at home of concepts that their child will be learning about at school. Obviously, you don't want to spend hours doing this, but the reason why it can be useful is that it gives the child an idea of what they'll be learning about. So when they're in the classroom, it's more likely to stick. So what this would require from a 504 plan or IEP standpoint would be potentially adding something like that the teacher provides lesson plans or worksheets ahead of time or something along those lines, so that the parents can kind of do the little bit at home, and then the child gets in there and they can feel more confident because, hey, I already kind of learned a little bit about this, and then the lesson goes better for them, and hopefully there's not as much repetition needed on the back end.
Kimberly.
Yeah, definitely agree with all of those. As far as working memory, and if we're talking about it in the executive functioning, older students, being able to take pictures of the board or pictures of the notes, or the overhead when teachers are teaching, so they can refer back to that. And yes, giving parents a heads up on the lesson plans ahead of time is a great one. But don't give a long list of directions either. I like the keep it simple, stupid kind of stuff. We do the KISS thing. If the simpler we can keep it for our kids, the better. And just lots of verbal and visual cues for them really assist in that too. And maybe, like you said, some note cards that they can put some reminders on there of some of the things that they're covering in class too. And being able to use those note cards when it comes time to take the test. So.
Right. And just as a follow-up to that, standardized testing, can you talk just briefly, Kimberly, about the like for SATs and ACTs and those types of things, what types of accommodations are allowed and what aren't for standardized tests?
To be honest, I'm not completely well versed on all of that, because but I can tell you that they need anything that they include pretty much in the IEP. So it really has to be an accommodation that they are using in the classroom in order for it to be carried through on their standardized testing as well. But I know, like for SAT, there are limits. So maybe Becky can talk to that a little bit more.
Yeah, I'm not as adverse in the high school testing, so your SATs and things like that, but I am a building coordinator for the MSTEP and all of our standardized testing at the elementary level. And Kimberly is right. Pretty much everything that is used on a daily basis in the IEP can be used, not everything, but pretty close, can be used and tied into their standardized testing. So all of their, anything from like fidgets to moving around to, obviously you can't have notes, but if a multiplication chart is even something that they use on a daily basis, to help them with that memory. I had an idea for that earlier too, but that's something that can be used on the MSTEP after third grade. So starting fourth grade, things like that. There's a lot of things, and like Kimberly said, a lot of those things, as long as they're using them every day in their IEP and it's written, they can use a lot of those accommodations on their testing.
Great. And Becky, your thoughts on memory aids?
Yeah, so the only thing that I wanted to add to that is I've had really good luck with putting important information into rhyme or song. So anything that you want those kiddos to remember, if you put it into a rhyme or a song and it's repeated, several times, it's something that you do fairly often, they will remember that, and they will use that on their test. They will use that when they're trying to retrieve that information, to repeat it back to you So that was one of my ideas for that, for those memory things. We're always making up a lot of rhymes and songs for those kiddos.
Right, and there's technologies, assistive technologies that can be used as well. Someone has talked about a pen where you can take notes with it, and
Live
then
scribe, yes.
live scribe, yeah, and then you can actually go back to a specific. It records the lecture at the same time, I believe, and you can actually go to a specific point in your notes and then hear what was being said at that time. So really some pretty advanced technologies available that can help as well. So, okay, so anti-seizure medications work by dampening the electrical activity in the brain. And while that helps to control seizures, it can also result in drowsiness and slower processing speed. Epilepsy itself, after effects of seizures and depression, can also contribute to that problem. So what are some accommodations and supports that can help with reduced processing speed?
So this is one that of course depends upon the severity of the symptoms, the extent to which a modification or an accommodation in the classroom would be appropriate versus actually placement in more of a self-contained kind of setting where the pace of the instruction moves a lot slower. But generally speaking, I would say things like extended time, but with the caveat that what we don't want to happen is that the child in the classroom doesn't finish the work that's been given. It's sent home, so now they've got whatever was left in class plus their homework. Like, they need to be kids, they need to have that time to decompress when they get home from school. So we don't want them spending hours and hours catching up on stuff that they didn't finish at school. So I normally will have we'll make that recommendation in combination with some form of compressed workload, so that maybe they're setting time limits. Like for math, we're going to work really hard on math for 20 minutes, and then whatever we don't finish, it's okay. It's not going to be graded. Some teachers will do like do every other problem sort of thing. So that can work as well. But I think generally just trying to minimize the amount of work that they're needing to do overall. If they can show they know how to do the work in 10 problems, they don't need to do 20, and they can then focus that energy on something else.
Great. Kimberly.
Yeah, I would completely agree. Reduce the volume of work, but be sure not to decrease the level of difficulty. We don't want to have our students have watered down curriculum. Provide an outline of the lesson. Reduce the need for writing. Many of our kids hate writing. It takes so long. So allow them to do bullet points rather than write a half a page or maybe 2 paragraphs instead of a couple of pages. Reduce the need for writing on tests. Do fill in the blank, multiple choice type things. And grade on mastery, not on work completed. I know sometimes we have some difficulties with teachers who say they need to do every single problem before they can get graded. And just because they can do 20 problems, doesn't mean they are only doing 5 problems out of the 20, doesn't mean they don't know the material. So grade on mastery and kind of push for that. Please grade on mastery, not for work completion.
Great. Becky.
Yeah, I was going to say the same thing about grading based on quality instead of quantity. So, those few things that they did do, you're like they said, we're looking for quality work, but maybe not that many or that of work. The other thing that I think that Kimberly said something that sparked, the writing thing. I have 2 kiddos on my caseload who have label makers, and it is a struggle for them. And so they are allowed to use that for a lot of their writing things, whether they're writing out sentences. That seems to occur for them, and it's less, it's less tedious. So we do have those label makers. And then I know personally for Eli, my own son, we have built in rest times or nap times, but rest times into his schedule. So after or prior to something that we know is going to be a little bit difficult of a task for him. So like math is a little bit more difficult for him. So prior to his math time, he would have that rest time that helps with that drowsiness and to kind of reset his brain before he does a hard task. So that's something that can be added into IEPs and 504s, is just that, built-in times throughout the day. Not even like movement breaks, just some place to decompress and get their thoughts back together and, kind of combat some of that drowsiness.
Okay, great. So some students with epilepsy also have either intellectual disability, autism spectrum disorder, or both. We could have an entire session on educational behavioral strategies for each of these conditions, but for now, can you highlight some of the most common and effective approaches that are used for both conditions?
So depending upon the severity of the disability, the majority of children who would fall under that category are most likely going to be in a self-contained classroom. And just the structure and nature of that classroom provides all the accommodations that they would need. At the high school level, this may mean that they're on a different track. So they may not be working towards a diploma, but rather a certificate of completion. So their curriculum will be more skills-based and focused on how to build their independence in daily life. They may have a job, where they're learning different vocational skills, things like that. And also, most importantly, would then be able to continue to receive those kinds of supports until they turn 26. So there are often community living programs that extend beyond the end of the high school years. And then as far as ASD goes, it really is called a spectrum for a reason. There's such a broad range. So a lot of the things we've already talked about will be appropriate or necessary for many of the children who have that diagnosis. But the additional thing that I would add would be probably more like the social component of it. So they may need a social skills group or social work support, a peer buddy, things of that sort to kind of help facilitate the social side of things for them.
Okay, great. Kimberly?
Absolutely, all of those. Just going to add, and I think she may have said this, just the structured classroom, consistent routines, and perhaps, well, not perhaps, giving them a cue as to, hey, this is going to be a change today. At the beginning of the day, our schedule is going to change a little bit, so this is going to happen. Visual schedules, a must for our students with autism, just so they understand that, and giving them that cueing that there might be a change. But yes, anything that we've mentioned already across the board will work for. And that's the thing, it'll work for all students. So if teachers implement these things and do them in the classroom, it's going to help all our kids.
Becky?
Yeah, the only thing that I would add to that is that in the world of special biggest, your biggest, what am I trying to say? Your biggest fight for behaviors will be, or your biggest chance to fight some of those behaviors will be positive relationship building. So like Angela mentioned, whether it be with a peer or a staff member, sometimes the staff members that we set up with students wouldn't be like your typical, hey, go see, the principal. It's the jam lunch lady or something like that. Somebody that they can just have a really positive relationship with will make wonders, will make their behavior. So having that check-in, check-out, and then obviously positive reinforcement and behavior systems. So anything that they would work for or keeping track of their behavior, things like that.
Okay. And applied behavioral analysis is a major thing for autism. Is that generally provided through the school district, or is that separate?
No, that's separate. That's separate.
Okay.
Mm-hmm. Now there's times when we would have their support person come in and be included in the IEP, because you want to make sure that what we're providing at school carries over into what they're providing at home. So we absolutely work together. It's just that the therapy does not happen at school.
Got it. Okay.
And I was just going to say that I think the more communication between an ABA therapist and the school, the better, because those behaviors, the positive behaviors you want to see will generalize better if same strategies and approaches are used in every situation. So a lot of times the teachers have a lot of insight into those, they're working with a child every day and they're seeing all this happening, so they can provide, useful information to the ABA therapist and then vice versa.
Right, and that gets back to the whole communication and collaboration that we talked about earlier today. So great. Does anyone want to share any strategies that can help with other cognitive difficulties that can go along with epilepsy that we haven't discussed yet? Things like language difficulties or maybe specific learning disabilities that might be related to the location of the seizure focus or things along those lines?
So I'll leave the learning disability piece to our educator professionals here, but I think the one thing that I thought about is fine motor skills, and we talked about it a little bit earlier, but a lot of the children I see struggle with this, and it can be a matter of stamina or also just coordination and control. And so oftentimes it's useful to have accommodations in their plan. So obviously occupational therapy as a direct intervention can be useful, but even just accommodations that minimize how much writing they're having to do. So the copies of notes, sometimes it's useful for them to have a scribe writing their answers for them when they're taking tests, so that they can concentrate on showing what they know and not having that barrier of the fine motor skills interfering with their ability to do that. And then from the language standpoint, a lot of it comes down to, maybe simplification of instructions, which we've talked about in relation to other things as well.
Great. Kimberly, anything you wanted to touch on?
Just as far as the language, I always tell parents, no one's going to advocate for your child more than you. So once they get in school and are around other students, especially if they're an only child, you may not be aware of the language, that there might be a deficit there. So certainly encourage someone to screen or request testing for speech and language, just to be sure that you're mitigating everything as they go through, because those language components are so important as they move forward learning to read stuff.
Becky, anything to add?
Yeah, just one little piece. Like we had mentioned before, a lot of our kiddos have a slower processing speed. So I've noticed that that a lot of them also end up, with like an expressive language delay or things like that, where they have a hard time. It takes them a while to get their thoughts out. And so making sure that everybody is aware of that and that they're receiving help for that through speech and language, I think is a really huge portion to that.
Okay, great. So we've talked about some specific cognitive problems and specific strategies for dealing with those problems. Can you talk about some of the more general behaviors that can help with overall cognitive function and school performance?
I would say that probably the biggest one is sleep. Obviously, there can be kids staying up late playing video games and stuff like that, but a lot of the children and teenagers that I work with epilepsy can also have difficulty falling asleep, staying asleep. There's actually certain types of epilepsy. Electrical status epilepticus in sleep is one of them that interferes with the actual sleep cycle. And so sleep issues can be, that carries over into the next day. So you don't sleep well, your attention's worse, behavior's worse, all of that. So that would be probably the number one. So having regular routines, talking to their physician about possible supplements like melatonin or something stronger if it's really a significant issue. Exercise can help with the hyperactivity. So being active is important. And then just having, I think the structure and routine is just key for every situation, home and school. And then of course, if there are, significant emotional and behavior problems, I think it can be really useful to have a therapist that the family works with separately from the school, who again communicates with the school, but to help support some of those things more.
Great suggestions. Kimberly?
I would agree as far as the therapist, because I think another thing that our students deal with are self-esteem problems. And so a social skills group would be really good for that. When you're not feeling good about yourself, you don't want to go to school and present yourself at school either, especially for our older students. So getting them involved in extracurricular activities so they can make those connections with other students as well, I think is really important, because then they will be getting that exercise too. But definitely working with a counselor or a social worker on self-esteem issues, and just providing lots of praise for what they do is really important for our kids.
Great. And Becky?
I was thinking, like, along with self-advocacy, learning self-awareness skills. So them trying to figure, I work with a lot of younger kiddos. So them trying to help them develop when they're feeling stressed, when they're not feeling right, and expressing that the right way. So I think that that's an important skill.
Right. I think that's self-advocacy in general. I remember with both of my kids times when they didn't understand something and they said, well, I didn't understand it. And like, did you tell your teacher? No. So yeah, I mean, it just the being able to ask for help is an essential part of self-advocacy. And I think that's something every child can benefit from. So
right. And you don't want to out yourself by being the one that doesn't understand. So that's why those skills are so important.
Yeah. Okay, great. Well, timing is perfect. We are about ready to transition now to our Q&A portion. So I'm going to open up the Q&A box and see what we've got and get started with that. All right. So how can we mitigate the impact of epilepsy on sleep hygiene? It's hard to get into sleep. The child is 3 years and 5 months and 26 days, so we have very specific information there. But yeah, what are just some, I guess, ways to mitigate the impact of epilepsy on sleep? And, well, obviously medications. If medication side effects are impacting sleep, you may consider switching medications or changing dosing schedules. But other things in terms of sleep hygiene that we can change or address that you found to be effective for kids with epilepsy who are struggling with sleep.
Well, I would say it's not necessarily specific to epilepsy, but any child who is struggling with sleep would will benefit from similar strategies. So having a routine, we're coming back to that again, having a routine, eliminating things like screen time, within the hour or so before bed, having, not having sugar. I mean, some of the common things there. Having a consistent bedtime is really important. And if you do all of those things and it's still not working, I have a 6-year-old daughter. She does not have epilepsy, but her sleep is terrible. So we use melatonin. But I would really strongly suggest just talking to the doctor, especially for that young of an age. Sometimes it can be just typical development where they go through phases of not sleeping as well. But sometimes there could be something else going on. They might need a sleep study so that their neurologist may recommend a formal study to figure out what the issue is. And oftentimes it's medication or melatonin, which is a natural supplement, are the typical recommendations that I see if the behavioral side of it doesn't help.
Right.
I know my doctor recommended for me, because I'm one that goes to bed and that's when the head turns on. Mm-hmm. And so it's constantly going. And it was, shut the screen time down, no television, no screen time, 2 hours before bed is where she told me, which was sometimes difficult. But then just getting into those routines and using calming things like lavender or taking a bath, a nice warm bath, and having those routines that it starts to say to your brain, this is the time I'm shutting down now. I'm not going to be here all the time. So your brain kind of gets used to you. This is the time I shut down, and then kind of lower the lights and just get used to winding things down.
Becky, any strategies that have helped with Eli?
No, luckily I've not had to deal with any sleep issues, but I think our other panelists
okay.
ideas.
All right, so another question. My son has a 504 and started testing for an IEP. Does he need both? And how do I make sure he's categorized in the IEP with other health impaired disorder, or do I need to wait until the results are evaluated? So I guess the key question there is if someone has a 504 and then get an IEP, do they need to keep the 504 plan? What are your thoughts on that?
You can have both. It seems rather silly to have 2 platforms in order to put in accommodations and supports. So I would recommend moving all of it to an IEP. but there have been instances where possibly the seizure plan is just in the 504 because that's a medical piece, and then the academic portion is in the IEP. So it's possible to have both, but as far as for case management, I don't know why you would want to have both.
And as far as the category that you're in, does that, it's not like there's a preferable special education category to be in, like OHI versus a autism spectrum disorder or something else. Is there a does the actual category that you end up in somehow limit the types of services you can get?
It does not. No.
That's,
and it should not.
Yeah, that's a discussion that probably all of us special ed teachers have with parents a lot, because the label or the categorization under there it doesn't change any of the services that they're going to get, or it shouldn't. You will receive all the services that that student needs that's in their IEP regardless of that categorization.
That's good to know. Yeah, and one other thing regarding why you might want to have a 504, even if you're getting an IEP, would be if you're an older teen and you're considering going to college. 504s will transfer to college, whereas IEPs won't. So that might be one situation. So, okay. Another question. May I ask if they might have any suggestions on behavioral aids and/or services for a child's IEP after recent neurocognitive disorder diagnosis? There's been previously no behavioral support on her IEP, and she's having trouble expressing herself.
Well, there's a portion on the IEP that asks if they've considered behavioral supports. So that would be a good opportunity to start that conversation. And clearly, if she is having some difficulty in the classroom right now, that would be something that you would want to bring up and bring in social work or behavior specialist, or even to have the doctor work with the team to say, these are the supports that I think the child would need at this time. But certainly you have to address any behavior needs in the IEP. So.
Also, I'd like to add, some parents don't often understand that IEPs are working documents, legal documents, but they can be changed at any time. At any time you can do an amendment or hold a new IEP, if things aren't going quite right. So to that parent, that's definitely something that she has the right to do at any time.
Absolutely.
Okay, great. So we do have a little more time for questions. So if anyone has additional questions, please do feel free to enter those. But one question I had relates to transition planning as part of an IEP. I've run into many parents who were not even aware that that was a requirement under an IEP, and who had teenagers in school. And I think it is something that sometimes gets glossed over or missed, or is done on a minimal basis. But Kimberly, can you talk about specifically what might be involved in a transition plan in an IEP?
Certainly, and Becky can probably jump in on the transition plan as well. Some schools start it at 14, some don't start transition planning until 16. But certainly what they need to be sure that they're looking at is what are the academics that are going to be needed, and what programs are going to be needed for this child to be successful and learn what he or she needs to learn to get to the career or what they want to be doing. And at that point, that student needs to be fully involved in his or her IEP to say, these are the areas that I'm interested in. How do I get there? And the school would be responsible for putting in those supports, putting in those classes, helping them achieve those goals that they want to achieve as they get older and when they get out of school. So transition planning is extremely important, and they need to bring the student in order to plan that. They can't do that in a vacuum because it's the student's IEP. So if that's happened, without bringing in the students and the parents, I'm sorry for that. But again, as Becky said, open up that IEP and say, hey, you know, what do you want to do moving forward? And it's difficult because some of the questions are really silly. Like, where do you want to live? What activities do you want to do after, you know, you graduate from school, or what do you want to do as an adult? And honestly, many of our kids don't, heck, sometimes I don't even know what I want to do when I grow up. So, but it is part of that planning. And so they need to make sure that they are bringing in the student, and the team is sitting down to make sure that they're doing what they need to in order to get them where they want to be. So Becky could probably talk more about that as well.
I have a ton of experience in transition plans, but I have been involved in a few. But one of the biggest benefit that I see and that parents need to make sure that they are including is also in that transition plan, bringing in those outside agencies. You know, for our kiddos who know that they're going to college, who are higher functioning, maybe some of that is a little bit less needed. But for kids who are transitioning to you know, a different type of job or out into the workforce, trying to be independent, getting some of those outside agencies in there as soon as possible in their high school years will help with that transition out into the world and being an adult.
Right. We just had a Learn and Share conference call on Michigan Rehabilitation Services, and that's one of those key agencies that can be brought in to assist with transition planning.
So yeah, so that would be very helpful.
Well, and you also need to know, as moving forward, is the student going to graduate? It's going to depend on, of course, what track he's on and he or she is on, and then also, is he going to go to a transition program provided by the school, or moving further ahead? So those need to be planned ahead of time, and that's a requirement of that IEP and that school to do that.
Okay. Well, it is 2 o'clock, so we're going to wrap up our conference, but I want to thank all of our panelists for an excellent discussion. I learned a ton in terms of very specific strategies and approaches that we can use. So I appreciate that and appreciate your time. And so you can go ahead and close your video and mute yourselves, and we'll just wrap up now. So, so thank you again to all of our speakers and participants for joining us and taking the time to learn together.